what I'm going to focus on tonight, there's three phases basically, or three different types of emergencies you could encounter that involve a gynecologic or really an obstetric person. And that is the antepartum, and the antepartum is prior to labor. Intrapartum is during labor and delivery, and postpartum obviously is after the delivery. And so those are the three different kind of like phases, three different types of emergencies, that a patient could suffer. Now, some of these you're going to find crossover into different areas. Like, I'll talk briefly tonight about placenta previa and abruptio placenta, which is typically an antepartum complication that occurs most often in the third trimester, but it also can occur intrapartum. And so we'll talk about things like that too. So what I'm going to focus on tonight primarily is, now you have a patient that is in labor who is delivering and you run into a complication. And so that's what I'm going to cover tonight. All right. So common unexpected complications in a field delivery. So these are common, they're common, not expected, because you would expect to have a normal field delivery, but something that you actually might run into in the field when you have a patient that you're delivering. An antepartum hemorrhage, and that would be primarily something like your abruptio placenta or placenta previa. Premature rupture of the membranes. If you have a patient where their amniotic sac has ruptured and has been greater than 24 hours from the rupture of the amniotic sac, then this patient is claimed to then have a dry delivery, because one of the purposes of the amniotic fluid, there's other purposes in utero, but one of the purposes of the amniotic fluid is actually lubrication of the vaginal canal for facilitation of the birth of the fetus. So if it's been greater than 24 hours since the rupture of the membranes, then what you get is a dry delivery. Okay, so I have a joke. Do you guys want to hear my joke? Prom joke? Any? Okay. So there's a class. Okay, this is when Larry was in 6th grade. And Larry's in 6th grade, and the teacher says, okay, I want you to think. They're doing a lesson on memory. She says, I want you to think as far back as you can. Like, what is like one of the first things that you can remember? So little Matt raises his hand and says, I can remember in 2nd grade, when I made my first Holy Communion. Oh, and she's like, oh, that's really good, Matt. And then she calls on little Susie, who raises her hand. And yes, Susie, what do you remember? She says, I remember my first day of kindergarten. She says, oh, that's awesome, Susie. And then little Joni raises her hand. Yeah, Joni. And Joni says, I remember my first birthday party. I can remember putting my hands in the cake on my first birthday party. And the teacher was like, wow, that's really something. You really, really remembered a long way back. That's amazing. Little Larry raises his hand. Oh, teacher. And she says, yes, Larry. And little Larry says, hey, I remember going to the prom with my dad and coming home with my mom.
Did you use my name because your daughter texted me this morning?
Absolutely, Larry.
All right.
Yep. All right. So anyways, prom. So as I referred, one of the other problems with the premature rupture of the membranes is if the amniotic sac ruptures too early, there's a higher chance of infection, like chorioamnionitis, where the amniotic fluid becomes infected and so forth. So, and that ends up, stressing the baby during the delivery. You don't want to have a stressed baby during the delivery, because if you stress the baby, it's a physical stress, physiologic stress. They use more oxygen, they use more glucose and so forth. So it's not good for, for a fetus that's being delivered to be stressed. Eclampsia, preeclampsia, eclampsia. Again, I'm not going to cover that today because that's a antepartum emergency, but your patient could be preeclamptic or eclamptic during the field delivery. and the patient could be preeclamptic and become eclamptic during the field delivery. Remember the difference between the preeclampsia and eclampsia is the preeclampsia is primarily where the patient has, well, and as far as EMS goes, the primary things we're looking for is the hypertension. And the two main things is hypertension and proteinuria. We have no way to determine proteinuria, so we're going to look primarily at hypertension. Peripheral edema is another thing, light flashes, headache, things of that nature. And that's the preeclamptic patient. If you have any patient that is complaining of headache, like dull, achy headaches, any light flashes, blurred vision, spots, has you know, an unusual peripheral edema, especially like, you know, pedal edema, ankle edema, and things of that nature, you know, you got to start thinking preeclampsia. But the true field diagnosis for preeclampsia is the hypertension. And again, I'm not going to talk a lot about it, but if you have a patient who has a systolic blood pressure greater than 150 and a diastolic greater than 90, if they don't know their pregnancy blood pressure. So one of the, something that's really important for you to ask of all pregnant patients is, what is your normal pregnant blood pressure? Okay. It's interesting because the blood pressure actually has a tendency to decrease during pregnancy and not increase. And that's due to all the physiologic effects of all the hormones, estrogen, progesterone, and so forth that's occurring. So you wouldn't expect this patient to become their blood pressure to increase. You would expect actually their blood pressure to decrease slightly. Although their volume has dramatically increased by like 30%, you know, and you know, increase of red blood cells, all this other stuff. But what you do want to ask is, do you know what your pregnancy blood pressure is? 150/90 is actually a fairly high blood pressure for a young adult. But that is the criteria. If this patient doesn't know what their pregnancy blood pressure is, or they have no idea what their pre-pregnancy blood pressure was, then what you would use is 150/90 as an indicator for preeclampsia. If they do know their pregnancy blood pressure, then what you do is you use a blood pressure that's 30 millimeters of mercury greater systolically and 15 millimeters of mercury or greater diastolically. So you take their pregnancy blood pressure, you add 30 to the systolic, add 15 to the diastolic, and if their current blood pressure is greater than that, then they are considered to be preeclamptic. That is considered to be hypertension during pregnancy. Okay, so that's a better indicator than 150/90. And then the transition from preeclampsia to eclampsia is when the patient actually experiences a seizure. And the seizures, again, the rule of thumb typically is this is a secondary seizure. It's not a primary seizure. You know, you could have a epileptic patient or a patient with a seizure disorder that actually seizes during the pregnancy or seizes during, you know, the delivery, but that's a little bit different. That's a, you know, that would be considered a primary seizure, you know, during the labor and delivery. Just make sure, but check their blood pressure, be sure. But a patient who's preeclamptic that seizes or who becomes unresponsive is considered to have transitioned from preeclampsia to eclampsia. And at that point, it's a critical emergency at that point. And the only way that they could eliminate the eclampsia or the preeclampsia is to deliver the baby. That's it. And that's why you're finding in some of these cases when patients have severe preeclampsia, where their blood systolics are over 160, their diastolics are over 100. If you have a patient with a systolic over 160 and a diastolic greater than 100, that's considered to be a critical preeclampsia. And at that point, they start looking at if they can't, you know, treat them effectively with medications, then they're going to look at actually inducing labor, and hopefully the gestational age is enough that the baby's going to survive. So that's, again, preeclampsia, eclampsia, and that can occur during the intrapartum phase. Premature labor is another. You know, it's kind of interesting. You read the literature now, and there's a lot of literature out there that's saying that COVID is causing a significant amount of premature labor. And the other thing that they're finding is that COVID is causing a large number of stillborn births, where these pregnant patients are carrying these babies into the 30 some weeks of gestation. and they're ending up that the baby then dies in utero, and they have to go through a stillborn stillborn labor process. And that's sad, but they're finding a large number. And it's kind of interesting, and I don't want to, I don't want to get political or, off topic or anything of that nature, but I just want to say, it's kind of interesting. And the reason why I've paid very close attention to this is because my youngest daughter, her and her husband, she's doing July. And so that's why I've paid particular attention to this. And it's kind of funny because, some of the stuff, even that the CDC puts out there is a little bit deceiving, because what they do is no disclosure. And so, you'll find people saying, well, no, there's no difference in, spontaneous abortion in patients with COVID or who had the COVID shot. And I'm not advocating one way or another. I mean, I'm not an anti-vaxxer. I got the vaccine. I got a booster. I got my flu shot. So I'm not advocating one way or the other. That's your own. I do believe it's your own personal choice. But anyways, but if you read the literature, and they're saying, well, there's no increase in spontaneous abortion. Well, they actually found a slight increase in spontaneous abortion with the COVID vaccine. But what they failed to tell you was there was a significant increase in stillborns associated with the vaccine. And so what they printed in the literature wasn't false, but they actually didn't tell the whole story. So that's what I'm saying. So don't, be surprised if you're reading some scientific literature somewhere that says, no, there is a dramatic increase in stillborn, and that was one study. But, you're going, well, the CDC said that there isn't, while they said specifically in spontaneous abortion, and that's 20th week or before. Anything after the 20th week is no longer considered a miscarriage or a spontaneous abortion. So, but anyways, premature labor. Problem of premature labor is that you're going to be delivering a premature baby. And the problem of premature babies is premature babies have a tendency to be low birth weight. Even if they're in the 30th week of gestation and so forth, where you look and say, well, developmentally, they probably have the ability to survive. They have enough surfactant, they have enough, lung capacity as far as tissue and so forth, and they'll be able to survive. But the problem is low birth weight babies typically don't do well, and low birth weight babies typically need some type of resuscitation outside of the normal drying, warming, and so forth. So abruptio placenta, we'll talk about that a little bit, where it's just premature separation of the placenta away from the uterine wall. Extremely dangerous. These patients a lot of times will bleed to death. Actually, Nick Heitzer, when he was going through the program, he was in his labor and delivery time, actually was up on labor and delivery when they brought in a patient who was an abruptio placenta patient. And I forget how far along she was. She was pretty far along, because it went in, I believe, when they did a C-section, try to save the baby. But I know the mother, I want to say the mother died and the baby died too. But this patient had just was exsanguating. And again, you have to realize one thing, that uterus, if that uterus has enough blood flow to support a fetus and grow a fetus, you got to figure that that's a significant amount of blood flow. So therefore, if you get, that placenta tearing away from the uterine wall, and again, when it tears away, basically what you do is when you tear away the placenta from the uterine wall, you leave vessels that are exposed and they're unopposed to any pressure or anything, and they just bleed freely. And they're arterial vessels too, so they're bleeding at whatever the patient's systolic blood pressure is. And so they can bleed to death very, very quickly. And the other sad part about that is as soon as you lose the placenta or the big portion of the placenta, you've also cut off that, blood supply to the fetus too. So in most cases, both the fetus will die, and in severe abruptions, so will the pregnant patient, which is sad. Precipitous delivery is where delivery occurs at a very rapid rate. And we know that, null-para patients, the ones that have never delivered before, have no kids, they may be in that first stage of labor for 12, 15, 18, 24 hours, before they actually deliver. So there's a lot of preparatory, physiology going on there. If you have a patient who goes through all the phases of labor and delivers within a few hours from the onset of true labor, it is considered to be a precipitous delivery. And the danger there is trauma to the mother and also trauma to the fetus. So it doesn't provide enough time for all the ligaments to stretch appropriately and so forth. And yeah, and the stretching is occurring over time. It's not just then, but it does set them up for trauma, both mother and fetal trauma. Malpresentation, we're going to talk about in a lot more detail. And a malpresentation is anything that presents in the vaginal opening that is not the vertex of the head, okay, the top of the head, the vertex, is considered to be a malpresentation. So just keep that in mind. And an umbilical cord emergency is where, you know, we'll talk about that, a prolapse cord, a nuchal cord, or whatever it would be. One other thing I want to talk about malpresentation too. The other malpresentation too is, we'll talk about this, is when babies are being born, they're occiput anterior, meaning that they're typically face down. The most common malpresentation is occiput posterior. That's where the occiput of the head is posterior and the face is looking upward. But don't be concerned with that. You could deliver that with absolutely no problem. You'll hear a patient saying that they had back labor, and a lot of times when the fetus is in that position where they're being delivered in an occiput posterior position, when the face is looking upwards, these patients experience a lot of low lumbar pain, and that's a lot of times they'll have that back, you know, pain. But you could deliver a posterior occiput very easily. So true labor is when you have the onset of the delivery process. So that's the labor process, is actually the delivery, the expulsion of this fetus. And in true labor, the thing that you look at, you know, our most consistent indicator of telling us how true labor is going and whether this is true labor or not, is you look at the contractions the patient is having. Now, the contractions are the uterus contracting, okay? And that's the muscular contraction of the uterus. And just a couple things, when the uterus contracts, it's almost like a wave-like motion, and the uterus begins to contract at the fundus, the top, and it's almost like a wave-like motion that moves downward. So the uterus just doesn't contract all at one time, because if it did, you wouldn't expel anything. What you would basically do is crush the baby. So when it contracts, it starts its contraction at the top, at the fundus, moves down through the corpus or the body, and down through the cervix. Okay, and that's how that baby is actually expelled, top to bottom. Okay, but we don't see that, we don't know that, but that's actually how the contraction actually occurs. And so the contraction, during the contraction, the patient is going to experience that uterine cramp, that uterine pain, and that is from the contraction of the uterus. And so that's the what we're going to call the contraction, because it's actually physically a contraction of the uterus, and that's what the patient is feeling. So with contractions, there are three things that you want to actually assess. You want to assess the duration of the contraction, meaning how long is that contraction? Is it 10 seconds? Is it 15 seconds? So the duration you actually measure from the onset of the contraction to the end of the contraction. So as soon as that patient says, ow, 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 it's starting, boom, you start measuring time, okay? And then, she's having the contraction, having the contraction, tell her, let me know when it subsides, let me know when it goes away. Okay, it's gone. Okay, the end of that contraction, the time between in seconds or minutes is the duration of the contraction. The intensity of the contraction is, you know, you can use a scale of 1 to 10, you know, on a scale of 1 to 10, with 10 being the most severe. Tell me where the contraction intensity is, and that's how painful is it. And then the frequency is the interval between contractions. And now here, this is interesting, because when you measure the frequency begins. So as soon as a patient starts having a contraction, that's when you start timing, okay? They have the contraction, it's going away. Contraction is gone. You then have a period, okay, with no contraction, and then boom, contraction starts again. That's when you actually stop timing. So the frequency, or the interval between contractions, is measured from the beginning of a contraction to the beginning of the next contraction. okay? And that's your frequency in minutes. Like you're saying, contractions are 3 minutes apart. That means it's 3 minutes from the beginning of the contraction through the beginning of the next contraction. That's 3 minutes, okay? So that's what you're measuring in true labor, and this is just a graphic of what's happening. Your intensity is obviously the height. The duration is obviously the width of this wave, and the interval is the beginning of this contraction to the beginning of the next contraction, okay? And typically, when you have a patient where the duration increases, meaning the contraction is getting longer, how long the contraction is lasting, the intensity is increasing, it's gone from a 5 to a 9, and the frequency, meaning the interval between the contractions, is getting smaller, it's shortening. And once you get to about 60 to 90-second length, duration of a contraction, most often it's more like 60 seconds, 45 seconds. Most often you'll reach 60 seconds, but they could last as long as 90 seconds, the contraction. And a +10, meaning that this patient's at the full intensity. This is a very strong contraction. And the contractions are less than 2 minutes apart. You probably are going to actually be delivering this baby, because this is now evidence that this patient is moving to the expulsion stage at this point, that they're going to deliver very, very quickly. This is the height of true labor at that point. Now, a pretty reliable sign of the onset of true labor is what's called the bloody show, and this has to be some British term, I'm assuming. But the bloody show is so this is interesting. At pregnancy, one of the first things that happens when a patient becomes pregnant is the cervical os, the opening to the cervix called the os, fills up with a mucus plug. And that's to prevent infection and invasion of any bacteria and things of that nature. And one of the first things to happen at the onset of true labor is the expulsion of the mucus plug. Okay, so this is nothing more than the mucus plug that's actually being discharged. It's being pushed out of the cervical os, the opening to the cervix. Now, notice this has some brown and red tinged, mucus. This is completely normal. This is not alarming. Okay, and it's just that mucus plug that could be blood tinged, could have that brown. That brown is digested blood, or not digested, but blood that's deoxygenated blood and so forth. So that's not alarming. Now, if you had red all around here and so forth, that would be alarming. Okay, but if the mucus itself. Now, here's another mucus plug that's discharged. You notice there's no color. It's basically just pure mucus. So there's no red tinge, brown tinge, or anything. That's also a bloody show. Okay, discharge of that mucus plug. Now, Braxton Hicks, we used to call Braxton Hicks false labor. And they changed that thinking years ago, where they said, well, Braxton Hicks is not really false labor anymore. Braxton Hicks now is thought to be preparatory labor. So you have true labor, and we know in true labor the contractions do what? They're regular, they last longer in duration, and they get closer in the interval. So they are occurring more frequently. And we know in true labor that, the contractions are throughout the abdomen. Okay, they're not isolating them anywhere. And pain relievers are not going to stop it, like, if the patient's taking Motrin or Tylenol or something like that. And they are having cervical changes like effacement and dilation. However, in Braxton Hicks, the contractions are very irregular. They may have a contraction, their next contraction is 3 minutes, and then all of a sudden they don't have a contraction for 17 minutes. And then they have another contraction, and then in 7 minutes they have a contraction. They don't have another contraction for 30 minutes. And then and the first contraction was pretty intense. The second contraction was like a 2. The third contraction was like a 5. The first contraction lasted 10 seconds. The second contraction lasted 30 seconds. It's like a V-fib of contractions. There's no organized pattern. There's no organized rhythm. And one of the things you'll find too is a lot of times with Braxton Hicks, there's a lot of lower lumbar pain, and they're feeling a lot of pain and discomfort there. And one thing you'll find with Braxton Hicks is if the patient gets up and walks, A lot of times the pain is relieved. And if they do take some type of pain reliever like Tylenol, well, typically they don't take Motrin when pregnant, but Tylenol, you might find that the pain is relieved a little bit. And typically there's no dilation, there's no effacement of the cervix. So the only thing I'm going to tell you is this. Here's one piece of advice that I will give you. If you arrive on the scene, okay, we used to call these Samsonite syndrome patients, and I'm sure that you've experienced this, that they call you and they say, hey, they call in a dispatch and they say, hey, I think I'm in labor. Okay, well, I need an ambulance now. And you go screaming down there, and the patient's standing on the street corner with their suitcase. Again, we used to call it Samsonite syndrome. And here's the pregnant patient standing in their driveway, standing on the street corner, standing on the curb with their suitcase. And you're like, okay, come on, get in. Well, one thing I'm going to tell you is be sure to assess that patient. And I'm also going to tell you this. If your pregnant patient is having any type of abdominal pain, any type of abdominal contraction, you must inspect for crowning. Okay, I'm going to say this again. If you arrive on the scene of any pregnant patient complaining of any abdominal pain or cramping that might be construed as a contraction, you have to check for crowning. Okay, even if they're presenting and you go, well, this is Braxton Hicks for sure. There are patients that present with Braxton Hicks and they actually deliver. Okay, so don't get caught off guard where you're bringing your patient and they lift up the patient's nightgown and they find that the baby's halfway out of her vagina because you failed to check for crowning. Okay, so you always got to check for crowning in these patients. All right, so what are the signs of active labor? Signs of active labor that you're looking for: contractions. Okay, now this is active labor. It's not the height of labor necessarily, but things that you're saying, okay, this patient's in labor. They're having contractions, and we know that the pattern is usually pretty typical, where the contractions are getting longer in duration, shorter in interval, and more intense. The amniotic sac often has ruptured. It's not normally some huge gush like a gallon of water just, squirted out from between this lady's legs. Most often, these patients feel like they peed themselves, and a lot of times that's what they think it is. So they might have, some wet underwear, the bed's wet, or the chair's wet, or something like that. But it's not going to be this huge puddle of water. At full term, there's about 1,000 mLs of amniotic fluid. I mean, so that's a significant amount, but it's not like this gush of water. Okay. And then the expulsion of the mucus plug, the bloody show. So if you have these three things, contractions, rupture of the amniotic sac, and expulsion of the mucus plug, then you could be pretty damn sure that this patient is in active labor. Again, this may be the patient's first child, maybe the second child, maybe the third child, and usually the labor stage goes on for hours. So if the contractions are not 2 to 3 minutes apart, they're not real intense, they're not lasting for 60 seconds or longer, then you probably got time to actually go ahead and transport this patient to the hospital. Not probably, you do, depending on how far the hospital is, unless you're in some wilderness situation or something. But I'm going to tell you again that you better check for crowning. You have to check for crowning, okay? All right, now signs of imminent delivery, okay? Now, these are the signs that you're going to say to yourself, well, we are going to set up shop and we're delivering here at the house. We are not going to move this patient because it's a danger to the patient, it's a danger to us, it's a danger to the fetus, it's a danger to the newborn baby. And these are signs that this patient is going to deliver now, okay? The biggest one is crowning or a presenting part. And we'll talk about a presenting part other than the vertex of the head and what you're going to do, okay? Because this could be an indication that you pack the patient and you go as fast as possible. But if you see the head in the vaginal opening, especially during the contraction, the head may disappear after the contraction, but during the contraction, the vaginal wall bulges, and you see the top of the head, then that is crowning. The maternal urge to push with the contraction, she wants to push. Every time there's a contraction, she wants to push. Okay, let me tell you this. If you're pregnant patient, if you're transporting a pregnant patient, you're with your pregnant patient, and she is not crowning, but she's having contractions, do not have her push. do not allow her to push unless she is crowning. Okay, I'm going to say this again. If you have a pregnant patient and she is not crowning and she's having contractions and she's pushing with her contractions, do not have her push. Okay, the best thing that you could do is when the contraction starts, you have her pant like a dog because by her panting, she can't contract her abdominal muscles and try to push. Because if she's pushing this fetus and she's not crowning, and that opening to the pelvis isn't wide enough, and they're not engaged just the way that they need to be, you could actually traumatize the fetus. So be careful. The pregnant patient also has this urge to move her bowels. Like she'll tell you, like, I got to go to the bathroom. I got to go to the bathroom. I got to go to the bathroom. You know, her rectum or bowels could be completely empty. But what this is that usually what this is caused by is the pressure of the fetal head on the rectum. And when it's compressing the rectum, what it does is it gives this mother the urge that she feels like she has to move her bowels. Now, here's the problem. If some of these patients think that they have to move their bowels, they go to the bathroom, they open the seat of the toilet, they sit down, they push, and they have their baby in the toilet. So I think, Larry, is that what happened? Is that why you are the way you are? Delivered in the toilet, maybe, Larry? I don't know. You know?
You know, I actually had a cord wrapped around my neck, Joe. So thank you very much.
But
And
you know
that, and I survived your paramedic. So.
but the difference though, Larry, is the cord wasn't the it wasn't a nuchal cord. It was the cord was placed around your neck after you were delivered. But anyways, that was a clothesline, I think. But anyways, and the other thing is the mother says, like, I'm going to deliver now. I'm going to deliver now. I'm going to deliver now. I mean, this is very, very similar to, and I'm sure that all of you have experienced it. Have you ever experienced in the back of the ambulance when the patient looks at you and goes, I'm going to die? And you're like, oh, no, don't say that, don't say that, don't say that. You know, they have that, feeling of imminent, like doom and so forth. Well, these pregnant patients have this feeling of like imminent delivery, like, okay, I'm going to have this baby right now. Pay attention to them. Again, at this point now, you are examining, you are looking for crowning, you are determining, you are looking at, the contractions, determining the intensity, you're determining the interval, the duration of the contractions and so forth, and make your decision at this point. But if you have all of these, your decision is to stay at the scene and deliver. Okay. Okay. Normal progression. So this is a patient who has a normal progression of labor. So the uterine pain occurs during the contraction. Okay. Contraction occurs during the contraction. The patient is having his uterine pain. It usually expresses abdominal pain throughout the abdomen. Okay. But when the contraction is done, the pain goes away. Okay. I'm going to say that again. When the contraction is done, the pain goes away. The patient's belly is not tender. That means when you palpate it, it doesn't hurt them. The patient's belly isn't rigid other than it being a pregnant belly. And the patient doesn't experience pain between the contractions. Now, they may experience discomfort. They may experience some lower lumbar pain, but they're not having this belly pain, okay, like during the contraction, okay? Now, again, if you palpate, the abdomen is a pregnant abdomen. It is not a rigid abdomen like a patient that has, an intra-abdominal bleed. And there's no tenderness on palpation, okay? And there's no vaginal bleeding, all right? If anything, you may see some amniotic fluid. It may be a little bit blood tinged, but there's no actual vaginal bleeding. That's normal. Now, if you have a patient that's having severe uterine pain during the contraction, you would think, well, that's the contraction. It's just a severe contraction. But if this patient has severe constant abdominal pain between the contractions, that is a red flag that this patient more than likely has an abruptile placenta, has torn away a portion of the placenta away from the uterine wall, and this patient is going to bleed to death. The patient may not survive, and there's a good chance if it's an abruption, the fetus isn't going to survive. Okay, so if you have a patient, okay, their contraction is done, but they continue to have severe abdominal pain when the contractions are over, and their abdomen is tender to palpation, that is a huge red flag for you to go. And when you go, be sure.
They're not seeing that. Nobody's seeing that. See, I'm telling you, if it goes down.
I got an open mic out there.
I got you, Joe. It was Eric Metz. Just keep a track of your mic, please. Thanks.
Okay, thanks, Larry. So if you find this, where this patient is having this constant severe abdominal pain between contractions and their abdomen is tender, you load that patient and you go to a facility that has the ability to do labor and delivery. Okay, it's like, follow your destination protocols, but you need to take this patient to a place that they do labor and delivery. Okay, that is typically a severe surgical emergency at that point. If they have vaginal bleeding, okay, and if they have, an abruptio placenta or something of that nature, typically they have vaginal bleeding. Now, they could have a uterine rupture. Could be that this patient has an anomaly with their uterus. Maybe they had some scarring, whatever it would be, and it's weakened, and they ruptured their uterus. With a uterus rupture, it typically results in 100% maternal death and 100% fetal death if they actually tear their uterus, because it just bleeds profusely. But again, vaginal bleeding. Now, one thing I also want to emphasize here is do not qualify the amount of bleeding, or maybe I should say, do not quantify the amount of bleeding to tell you how severe we already know that it's so difficult to try to estimate the amount of blood in the field. I mean, you could take a patient that has 50 mLs of blood, squirt it on their white t-shirt, and it looks like they bled to death. And you're like, well, wait a minute. Bill Brown actually did a study at YSU years and years and years ago. But listen to this. This is interesting. He actually got whole blood that was expired from the hospital. Okay, whole blood that was expired from the hospital, and they went down in the bathroom down by the media center, and they got different clothing and gauze pads and abdominal pads, and they squirted different volumes of blood on these items. And then they actually took pictures of them, and they put them on slides, and it was designed to try to get people to estimate the amount of blood loss. And it was so interesting because, like I said, it was like 50 mLs of blood, whole blood, on a t-shirt looked like this patient lost 2 liters of blood. And it was like, it was so deceiving, but it was so funny. They're down in the bathroom squirting blood on the ceramic floor, and I'm like, today, oh my God, I couldn't imagine. That'd be a hazmat incident. But in no way should you say the amount of vaginal bleeding tells you the criticality of the patient. Because and we're going to talk about this a little bit with the abruptio placenta too, because a lot of that blood may actually be housed behind the placenta, between the uterus and the placenta, maybe trapped by the head of the fetus, whatever it would be. So the amount of vaginal bleeding in no way is an indicator of the severity of the patient and the amount of blood that she lost. What you really got to look for is signs of hypovolemia. You got to go back, you got to look for your signs of hypovolemia, look at especially the pulse pressure, the narrowing pulse pressure. You can look at the blood pressure, but more importantly is the pulse pressure, tachycardia, skin signs, capillary refill, and things of that nature. Okay. But just be aware. But this patient needs to go. This is an urgent patient, a surgical emergency. Get them to a labor delivery unit. So one thing you learn, if you have a patient, now this is usually 3rd trimester. This could occur during the intrapartum phase when the patient is actually beginning to deliver or at the onset of true labor. But a placenta previa. In the old days, again, here's Matt, got to unteach what, we taught him years ago. And one thing that we taught you years ago was that a placenta previa was bright red, painless vaginal bleeding. I mean, it was bright red. That was one of the qualifiers, bright red and painless. And the reason why they said it was bright red is because it's where the placenta is located, because it's located so close to the cervical os and the vagina that it would leak out, and it was pretty much not very deoxygenated, so it would be more bright red. Well, they said that's bullshit. The color of the blood has nothing to do with it. The key is you have a patient who's having vaginal bleeding, but no pain. Now here again, let me be careful. If the patient's in labor and they're only having pain with the contraction, but they have vaginal bleeding, okay, not a tint of or blood or a faint amounts of blood, and so forth, but having vaginal bleeding. You going, buddy? Okay, come here. Hurry up. Oh, you're bringing my phone. Okay. All right. Okay. All right. Okay. Love you.
I'll just give you your phone, that's all.
Okay. All right. Thank you. All right. Bye, sweetie. All right. So if it's painless, okay. You want to tell them? Tell everybody. Okay. Avery wants you to see all her stickers she made for me. Those are all her notes she made, my little granddaughter. So she want to be sure to point them out. Anyways, I never got any stickers from you, Larry. But anyways, painless vaginal bleeding, okay? So again, patient has the contraction. They're having abdominal pain, but between contractions, they're not having any pain. That's the painless vaginal bleeding. But they got vaginal bleeding, so this is a red flag, okay? This is an indication that they have a placenta previa. Okay, and notice one thing, that the placenta is normally implanted. It's implanted superior and inferior in the uterus, okay? So this is uterus here. It's superior where it's high, and it's back in the uterus. That's normal implantation. And you have what's called a marginal placenta previa, where you can see it's on the margin. This is the cervical os right here. This is the cervix, okay, the cervical os. Okay, this is the fundus, this is the corpus, and the cervix is the neck, okay? And this is right like on the edge of the cervix. That's why it's called a marginal placenta. A partial placenta is where that placenta is actually partially covering the cervical os, and the total placenta previa is completely covering the cervical os. Now here again, one of the problems we experience in the pre-hospital environment is how many times, especially if you work the inner cities, how many times have you gone on calls of patients that are pregnant that, one, can't even tell you that they're pregnant, two, they've had zero prenatal care, they don't know how long they've been pregnant, but they're in labor. And the problem with that is that you could be actually dealing with a patient that has something like a full placental previa, a total placenta previa. And what do you know about this? You're not going to deliver this, but she's going to bleed profusely, because as the cervical os begins to dilate, okay, and the cervix begins to efface and thin out, what's it doing? It's tearing those vessels away from the uterine wall. And this baby now, she's having contractions, and she wants to push, and that baby now is restricted from moving forward. And so she's basically traumatizing the fetus in the uterus from the contractions. I mean, it's nothing but bad. So again, if you have a patient with painless vaginal bleeding, third trimester or intrapartum in this case, you need to load your patient, and you need to transport expeditiously. Because again, even if it's marginal, this small amount may be a dystocia where it prevents this fetus from being delivered, especially something in this case, definitely in this case, okay? All right, here's another. They classify these as a type 1, type 2, type 3, and type 4. Same thing. This is a marginal. This here would be considered a partial. This here is considered, for the most part, a total. And this one here is a total, too. This one just isn't as severe of a total. So you might see these classified as a type 1, type 2, type 3, and type 4. Then abruptio placenta. So abruptio placenta. Now, here, let me go back. So placenta previa, remember, the placenta should be up here, high in the fundus and posterior. But with a placenta previa, the placenta is abnormally implanted. It's implanted in an abnormal position within the placenta. Whereas in an abruptio placenta, the placenta is typically implanted in the correct position, maybe a little bit off, but usually still high in the fundus and posterior. But with an abruptio placenta, think of it as an abruption, the placenta prematurely separates away from the uterine wall. Okay, keeping in mind there is what's called the decidua, and there's arterial vessels in there. Okay, and what happens is those arterial vessels, when that tearing occurs in here, those arterial vessels and venous vessels are left exposed. And again, that arterial vessel is going to pump blood out at the systolic blood pressure of the patient, okay? And now, okay, so now what you could have here is, now keep in mind that the fetus would still be attached to the umbilical cord here, okay? And in this case here, this is called a partial separation because the margins here stay intact, okay? And the bleeding occurs in this area here. But because it's under high pressure, because it's arterial, continues to bleed and bleed and bleed, and it's like a huge hematoma that's forming. They've had patients that have lost 1 to 2 liters of blood behind the placenta with the margins still intact. Now here, let me ask you something. If the margins remain intact, and you got 2 liters of blood behind here, but the margins are all still intact, will there be any vaginal bleeding? And the answer to that is no. There's no vaginal bleeding. There's no vaginal bleeding because the margins of the placenta are still intact. All the bleeding is occurring behind it like a hematoma, but this patient is going to experience what? Severe abdominal pain that's constant, okay, between contractions. They have no vaginal bleeding, but will have definite signs and symptoms of hypovolemia. In a partial separation, you notice that one of the margins has actually torn away, and this patient is going to have vaginal bleeding. But again, if the head of the fetus is engaged already in the pelvis, it may be blocking the bleeding too. So you're really looking for the painful vaginal bleeding here, having pain. And in this case here, this is a complete separation here. And in this case here is where the placenta has completely separated away from the uterine wall. But in this case, the bleeding is still being concealed because it hasn't actually moved down to the vaginal opening. Now, in this case here, with a complete separation, it could be a concealed hemorrhage, or it could be a severe hemorrhage too. Or again, if the head is engaged, you might not see the vaginal bleeding that we think. So here again, it's the same thing. The amount of vaginal bleeding in no way tells you the amount of bleeding that this patient is actually experiencing. So rely on your clinical signs and symptoms more so than anything, okay? With abruptio placenta, again, what you're going to find, I thought I had a sign there. What you're going to find with the abruptio placenta is this patient is going to be the patient that has pain. What the heck? What happened to my slide? I don't know. It's probably in there somewhere else. They're going to have painful vaginal bleeding. They're going to have pain between contractions. It is going to be painful. Their abdomen is going to be tender. Okay. This is another patient here that may have very little vaginal bleeding, but this patient may look like they're hypovolemic. They're hypovolemic. These patients, again, are surgical emergencies. These patients need to be transported immediately to a labor delivery unit, regardless of what's happening with the fetus, regardless of their crowning or whatever is happening, they need to go, okay? These abruptio placenta patients a lot of times will bleed to death, okay? Okay. Because we deal with such a large number of patients in the pre-hospital environment that a lot of times lack prenatal care, and we get on the scene and they say they're in labor or they're having contractions, and we have no clue how far along they are, how many weeks of gestation, you know, and all of a sudden we're like in complete dark, you know. So are we going to be delivering a 24-week-old? Are we delivering a full term? Are we delivering a post-term? What are we delivering here? So a quick, easy way to estimate gestational age, and they recommend you do this with a centimeter tape measure, but I don't know if anybody who carries like a old, what do you call them? The tailors carry that, you know, cloth tape measure. I wouldn't pull out your, like, you know, DeWalt tape measure or your Lufkin or whatever kind of tape measure you use, you know, your 16-foot rigid blade. But anyways, the easy way to actually estimate your gestational age is that you will go from the symphysis pubis, okay, the symphysis pubis here, the bony symphysis pubis, and you'll go from there and you'll measure up to the top of the uterus, the fundus of the uterus. So these represent the uterus at the gestational ages, okay? So here, let me just say this, because I don't know if anybody who carries a centimeter tape with them. Here's one thing I'm going to tell you. I'm going to tell you this. is if you feel the fundus of the uterus, the top of the uterus at the umbilicus, then you're at about 20 weeks of gestation, okay? If you got a patient in labor and the fundus of the uterus is hanging out with at the umbilicus, yeah, you're going to be delivering an extremely premature baby, okay? If the fundus of the uterus is up at the xiphoid process, they're about 36 to 38 weeks of gestation. You know one thing, if they go now, they're perfectly fine. They got a great number of weeks of gestation, okay? Notice one thing, at 40 weeks, okay, of pregnancy, the uterus drops. Now, again, when you talk about gestational age, it's 38 weeks of gestational age. It's 40 weeks from the last menstrual period, because you got 2 weeks there in the menstrual cycle. After the last menstrual period, there's 2 weeks, and then ovulation occurs at that point. So that's why they say 40 weeks of pregnancy, but that's from the last menstrual period. It's typically 38 weeks of gestation. But why does it drop? Well, it drops because the fetus now is engaging. It's beginning to engage and going through the 7 cardinal movements, to engage in the uterus and in the pelvic opening to be delivered. So that's why you get a little bit of the drop. But the higher the top, so here's what I'll tell you. The higher the top of the fundus of the uterus is to the xiphoid process, the closer it is to the xiphoid process, and it's hanging around the xiphoid process, feel pretty comfortable. If the top of that uterus is closer to the umbilicus, you're going to be delivering a really premature baby, okay? Again, we said the placenta normally implants here in the fundus of the uterus, high and posterior. Just want to point out 2 structures, the pubic bone here and the sacrum here, because these may actually cause some issues. Now, this here, right here, is the cervix of the uterus. You can see right around the head. This is the cervix. This is the cervical os. This is the vaginal canal. Whoops. Okay. All right. So you can see that. This is the body of the uterus. And again, this is the fundus of the uterus. Okay. All right. Just for points of reference there. So 20 weeks of gestation. So if you arrive on the scene and you have a pregnant patient, and whether the patient knows that they're 20 weeks pregnant, whether they have no idea how far along they are pregnant, but you could feel the fundal height at the level of the umbilicus. Oh, boy. Wow. Sounds like they needed a courtesy flush there. All right. At the height, okay, so the fundus is at the height of the umbilicus, 20 weeks of gestation or higher. Any patient who has 20 weeks of gestation or longer or older weeks of gestation, okay, gestational age, here's your pre-hospital care, okay? These patients always will get a non-rebreather of 15 liters per minute, regardless of what the pregnant patient's SpO2 is. They can have an SpO2 of 99%. And if this patient was in a car crash, they're traumatized, they're having chest pain, they're having difficulty breathing, whatever it would be, they're getting a non-rebreather of 15 liters per minute, okay? And the reason for that is because, remember, these patients have a tendency to compensate by actually reducing the circulation to the uterus, okay? They'll actually constrict those placental uteral vessels, okay? So in order to maintain oxygenation of the fetus, regardless of the pregnant patient's SpO2, they go on a non-rebreather 15 liters per minute, okay? Any patient at 20 weeks gestation or older, you're going to elevate the right hip, okay? So you don't want to put them in a supine position, okay? You're going to elevate the right hip. You could put them in a left lateral position. And the reason why they elevate the right hip is because the uterus has a tendency to sit, well, it's in the center, but the inferior vena cava has a tendency to be a little bit lateral, okay? It's not necessarily midline, a little bit lateral to the right. And so that's why you elevate the right hip, so you could take the fetus and roll it off of the inferior vena cava. And what you're trying to do is prevent supine hypotension syndrome, okay? If the patient goes into cardiac arrest, you have to do manual left lateral uterine displacement, LUD, okay? Lateral uterine displacement if in cardiac arrest. And because what they're saying there is with the heavy weight of the uterus pressing on the inferior vena cava, and Larry had covered this, if you're reducing that blood flow back through the inferior vena cava, again, we know that chest compressions are terrible at best. And if we're not able to move that blood flow now through the inferior vena cava because of poor pressure and because of the weight of the fetus pressing on it, our preload is going to be pretty much, nothing. Our cardiac output is going to be nothing. Our coronary and cerebral artery blood flow is going to be nothing. So you got to get the heavy weight of that uterus off of the inferior vena cava. And all you do is elevate the right hip with some pillows, or you could put the patient in a right lateral recumbent position, left lateral recumbent position, whatever it would be. If they are in cardiac arrest, you could do manual. This is the LUD, lateral uterine displacement. This is this is the right side of the patient here. And again, you want to move the uterus off this way, because if you pull it this way, the inferior vena cava, remember, is somewhat right, lateral. It's more lateral to the midline, heading towards the right side. So you would get on the left side of the patient and pull the uterus over towards you, or you could go on the right side of the patient and push the uterus off to the left side of the patient. And that would be the lateral uterine displacement. And that was recommended in the, I don't know if those were the 2020 guidelines or 2015. I can't recall offhand. It may have been the 2015 guidelines when this came out. But anyways, this was recommended by the Emergency Cardiac Care Committee through the American Heart Association in the update. So gestational age, last menstrual period, again, is 40 weeks. Embryonic growth gestation is 38 weeks. Anything preterm. Now, you're going to find this is going to be, I'm not going to say it's controversial. It's depending on the source that you read. But for the purpose of this and the sources I use, they consider preterm to be less than 37 weeks of gestation. And I think that's pretty consistent with PELS, too. And post-term is anything greater than 42 weeks of gestation. Don't think like, oh, this is great. This baby's 44 weeks old. I mean, and we're going to deliver them. They're going to come out and they're going to sit down and have a beer with us. That's not necessarily a good thing. Preterm babies and post-term babies both suffer some physiologic consequence. One thing about post-term babies, a lot of times born to diabetic mothers have extremely small glycogen reserves, and they become hypoglycemic very, very quickly. So that's one thing you have to worry about them. So labor and delivery terms, effacement is the thickness of the cervix. And what happens when the cervix begins to thin out, it's called effacement. So the cervix is like the lip of the old Coke bottle, that lip on the old Coke bottle, the glass bottle. And what happens is as it thins out, that's called effacement. Dilation is the cervical os, and all that is the cervical os is opening, okay? So once the cervix is completely thinned out, it's called 100% effacement. And once the cervix is completely dilated, it's at 10 centimeters dilation. Position, when you hear the term position, it's the relationship of the fetal presenting part to the birth canal, okay? So it's like occiput anterior is the position. That means the occiput is on top and the face is down. That's normal. Occiput posterior is it's on the bottom, the face is up. That's the position. Presentation is different. If you're calling in and the physician or the nurse says, what is the presentation or what's the presenting part? That is whatever is showing in that vaginal opening. If it's the head, you could just tell them it's the head. You can tell them it's the vertex. If it's the crown of the head, it might be a foot, it might be a hand, it might be an eyebrow, it might be a chin, it might be a nose, it might be a shoulder, could be a knee. I mean, whatever it is that's actually presenting in that vaginal opening is the presenting part, okay? Here's your dilation effacement. Here's the cervix before it effaces. Here's the cervix. You can see it's all thinned out. This is 100% effaced. Here's the cervical os right here. It's not dilated. Here's the cervical os at a 1 centimeter dilation. Here's 5 centimeters. Here's 10 centimeters, 100% effaced. And you can see that this is ready to go. Now, notice one thing here. If that placenta was right here, as this cervix is thinning out, it's tearing away at those vessels. And as it's dilating, it's tearing away at those vessels. And that's where you're getting the bleeding to occur. Here's normal crowning right here. So if you see this in the vaginal opening, I can guarantee you one thing, you're going to deliver. This is normal crowning. Okay, this might be during a contraction because you can see the vaginal walls, you can see the head bulging, okay? All right, occiput anterior position. We talked about that enough. This is the normal occiput anterior. Back of the head is pointing upward, face is pointing downward. That's the normal position to deliver. Okay. Occiput posterior is the most common malpresentation. Although it's called a malpresentation, you should not stop delivery. You should continue with no problem with the delivery if it's an occiput posterior. The only thing is it might be a little bit more difficult, might take a little bit more contractions and pushing by the patient. Okay. Here's an occiput posterior, face is facing upward. What's one thing we notice right away on this baby that we need to take care of immediately? Somebody?
The cord around the neck.
Yeah, nuchal cord.
The cord.
Yep, immediately you need to actually try to loop this cord over the head. And if you can't do it, you're going to cut it. You're going to clamp it and cut it. Okay. 95% of all labor the presenting part is the occiput or the vertex. So that's good. 95% of all labor and delivery, you're getting the top of the head, actually. All right, so let's talk about some complicated deliveries. What's the problem here? Somebody tell me, what is the problem here? This obviously is a normal occiput anterior, normal position, okay? The head is the presenting part. That's normal. What's our problem here?
The water hasn't broken.
Yep, the amniotic sac is still intact. Not a problem. Don't pull out your buck knife that you carried for the last 20 years, you know, in your little pouch, and now you say, I finally have a reason to use it. Don't pull out a scalpel. Don't pull out your scissors. All you do is take your thumb and your index finger, take the amniotic sac, and it'll rupture, and just pull it away from the face. This isn't going to do anything. Just make sure that you don't allow the chest to be delivered with this baby still in the amniotic sac, because they're going to start aspirating large amounts of fluid. Okay? All you do here is rupture the amniotic sac away from the fetal head. One of the problems you're going to run into, one of the common complication that you're going to find in the field is what's called a dystocia. Now, dystocia basically is a term that says there's an impedance to the normal progression of labor because either the head is too big for the pelvic opening or the pelvic opening is too small for the head of the fetus. But there's a stop. Dystocia is really where there's an abnormal stoppage or impedance to the normal labor process. Something's causing this to not continue. Again, pelvic could be too, opening could be too small, fetus is too big, uterus may be too weak to expel it. Maybe this patient has a condition, maybe they have some kind of, you know, myopathy or something where it's actually affected the uterus. Maybe they have some nerve condition where they just don't have strong enough contractions to expel the uterus. So anything that's going to impede the delivery of the uterus is considered a dystocia. Another complication, we're going to talk more about that. Another complication is multiple gestations. So multiple births, you know, multiple babies. You could deliver twins in the field. I had 5 field deliveries. I had 1 set of twins in my field deliveries. And the issue with the field delivery of twins is twins have a tendency to be low birth weight babies. And they're low birth weight babies because there's more than one baby. And so low birth weight babies have a tendency to need a little bit more resuscitation or care. And when I talk resuscitation, I'm not talking about intubation and drugs and just, you know, I'm talking about resuscitation, meaning they may need a little bit more stimulation. They may need some blow by O2. They may need, you know, bagged for a short period of time, whatever it would be. And all that criteria has changed too. There's some big changes in how you treat neonates too. So, but that's a problem with the multiple gestations. Malpresentation, again, is something other than the vertex of the head. Most common is a brow, meaning the eyebrow, a face, a shoulder, or a breech. Okay, those are malpresentations. And the general rule with the malpresentation, except for some of the breaches, is if you go and you look for crowning and you see an eyebrow, you see the face, you see the chin, you see the shoulder, you see a foot, you see a hand, at that point, you immediately transport that patient. You have that patient pant. Do not allow her to push. You contact the labor delivery unit or whatever your protocol is. Contact the emergency department. Whatever your protocol is, you tell them what you got. They may have you give a tocolytic drug. We'll talk about those a little bit later. But you don't have them push. I'll see you, sweetie. I'll see you tomorrow. Bye. Love you. Bye. Okay. 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 So again, in these situations here, you go. Do not allow your patient to push. During the contractions, have them pant. Patient gets a non-rebreather. If you have time, get an IV line. Again, call in. Make sure you notify them what you're bringing in. Make sure you're going to a labor delivery unit. And again, they may tell you to go ahead and give a tocolytic agent like mag sulfate. Nitro is an off-labor use as a tocolytic. You know, nifedipine. I don't know if anybody's carrying nifedipine anymore. You guys aren't carrying nifedipine, are you, Matt, Larry?
No.
No, I didn't think so. We used to carry nifedipine. For the old time, for the really experienced people out there, we carried 10 milligrams of nifedipine, and it was in a capsule. And we would take a needle, we would puncture the capsule, and we would squirt it underneath their tongue. That's how we gave them the nifedipine. But they had some problems with it that these patients were seeing huge declines in pressures and so forth. So anyway, so these patients need transported immediately. Shoulder dystocia. Now, a dystocia is impedance to the delivery. A shoulder dystocia is where the shoulder is causing this baby not to be born. The shoulders are hanging up behind the symphysis pubis and the sacrum, and they're causing this baby not to be able to be delivered. Now, 1 in 300 patients is a shoulder dystocia, 1 in 300 deliveries. And it develops intrapartum. So it doesn't matter how much prenatal care they had. It doesn't matter if they had a sonogram last week. It doesn't matter. A shoulder dystocia occurs intrapartum during the labor and delivery process. So there's no way to actually, predict it. Okay. But what happens in the shoulder dystocia typically is both shoulders are trying to get through the pelvis at the same time, and it can't happen. The width of the pelvic opening is not big enough. Now, this is what you're seeing. Now, this is a normal delivery here. And if you notice, the right shoulder is still behind the pelvic inlet, but the left shoulder is already out. This is normal, okay? This is normal. And you remember where you say, like, okay, so what you're going to do is you're going to put a little bit of upper traction on the head and the neck, and that's going to deliver the bottom shoulder. Then you apply a little traction downward, and that's going to deliver the top shoulder. And that's actually how you would normally deliver the shoulders. The problem with the dystocia is both the shoulders are trying to get through at the same time, and the diameter is too wide. You can't do it, so this labor is not going to progress. The shoulders are hung up. But what you got is you got the head that's actually delivered. The head is delivered, and you're telling the patient to push, because during a normal labor and delivery, as soon as she starts having that contraction and she's crowning, push, 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 push. You want her to push, okay? But in this case, she's pushing, 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 and nothing's happening. Next contraction, push, push, push. She's pushing, nothing's happening. Next contraction, push, push, nothing's happening. Okay, that's your dystocia. Again, it's from the shoulders. You got to think shoulder dystocia. So some of the things that may cause this: diabetes mellitus, maternal, obesity, prolonged second stage of labor. Fetal may be post-maturity. The baby's just too big to be delivered at this point. Large fetal size. Okay. Some of the complications, fetal complications, asphyxia, because all of a sudden now you're just pushing, 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 pushing. You're and you're not moving anywhere. So asphyxia may occur. The traumatic brachial plexus injury, the brachial plexus. Actually, these kids could suffer where if you injure the brachial plexus here that controls the upper extremity, they could develop paralysis, weakness that's permanent. Humeral and clavicular fracture, sometimes actually fractured the clavicle to deliver, not you, okay? Maternal trauma to the uterus, vagina, perineum. They're pushing, 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 pushing. Nothing's happening. The shoulders are hung up. This is like this is like you having barrel trauma from you trying to blow out against something with this tremendous impedance. You can't do it. So so again, trauma can occur from this. Okay. So you have a normal labor and delivery, but it's not progressing. Okay. There's your tracheal plexus injury. Okay. Brachial plexus injury. Okay. Okay. One thing you might find, and this, I didn't make this up. This is a true medical term. It's called a turtle sign. Okay. The turtle sign, all I can think about is the Michael Myers movie with Fat Bastard. Every time I think of turtle sign, that's all I can think about. I have a turtle poking out. But anyways, turtle sign. So what you have in turtle sign is this. During the contraction, you're telling the mother to push, 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 push. Remember, she delivered the head. But all of a sudden, no progression. Contraction's over, and all of a sudden the head sucks back against the vaginal wall, and you can see what's happening here with these cheeks and so forth. The head's pulled back. Next contraction, push, 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 push. Nothing happens. Head retracts back, and you see these cheeks are just like this because they're being pulled again back in because the shoulders can't get through that pelvic opening. Okay, the head's not going to go back in the vaginal canal. Okay, that's not going to happen. But what you're seeing is the head retract, the neck retract, and so forth. But during the contraction, the neck elongates, but you don't get anywhere with it. Okay, here's another turtle sign here. Okay, another one. Notice the position of the legs. Okay, the best way that you could actually reduce a shoulder dystocia is by doing what's called the McRoberts maneuver. And the McRoberts maneuver, and let me tell you this, anytime you have a patient that you're going to deliver in the field, you should do this anyways. And the McRoberts maneuver is you take the knees and you get them as high up on the chest as you can. And again, if you look at this picture here, okay, the legs are up, knees are up, okay? And what that does is it actually shifts the pelvis towards the head, shifts the pelvic cephalally towards the head, and it actually opens that pelvic opening. It drops the sacrum and it lifts the symphysis pubis, and it may open that pelvic opening enough that now you could deliver the shoulders. Okay. If the McRoberts positioning, where you take the knees that are on the chest, if it's not successful, that what you could do is you could do suprapubic pressure. So here's the McRoberts position. Get the knees up, get the knees as close to the chest as possible. Suprapubic pressure. So if you still can't deliver with the McRoberts, what you're going to do is you're going to take your fist, you're going to go right above the symphysis pubis, and what you're going to do is you're going to push down. You're going to push down steady, and you're going to push down hard, probably hard enough that you would try to collapse like a tennis ball. And what that's going to do is it's going to collapse the shoulders, and that with McRoberts position typically is enough to go ahead and deliver, okay? McRoberts and suprapubic pressure is effective in 42% of the cases. See, it could be an effective maneuver. Now, if that doesn't work, you know, they may tell you try the Gaskin maneuver, and the Gaskin maneuver basically does exactly the same thing as McRoberts, where it actually drops the sacrum and it pulls the symphysis pubis more cephalid, and it shifts the pelvis where it opens that opening a little bit. This is the Gaskin maneuver. It's elbows and knees, okay? The only thing is you really can't transport your patient in this position. That'd be really difficult to do, okay? So if you got a shoulder dystocia, you're not making progress, get the knees up on the chest. Even if you're doing any delivery, get the knees up on their chest. And if you still aren't delivering those shoulders, try the suprapubic pressure, okay? If you have a face brow and compound presentation, a face presentation is the face is the presenting part, a brow is where the eyebrow is the presenting part, because these are common ones. And if you look at this, the face presentation is 0.8 centimeters greater than the vertex. Meaning if you got the face in the vaginal opening and so forth, then that face is a hyperextension, okay? And that is going to be in this position here, and you're not going to be able to get it through the pelvic opening, okay? Because it's 0.8 centimeters larger, and a brow presentation is 1.5 larger than the vertex, okay? So what that means is that they're going to be too big to try to get through. A compound presentation is any other part is in the vaginal opening, or the head, I'm sorry. The head is in the vaginal opening like it normally would be, or both feet like a breech, and you have an extremity, like the hand and the head, okay? We have both feet in the hand. That's considered a compound presentation. If you have a compound presentation, a face presentation, a brow presentation, a hand presentation, a foot presentation, if you have any presentation at all, do not have the patient push. During the contraction, pant, 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 pant. Do not have her push. You're going to load this patient, and you're going to go to the nearest labor delivery facility on the red. This is an emergency. Do not attempt to deliver, okay? Do not attempt to deliver. Do not allow the patient to push. You got to coach her. You have to coach her through it so she's not pushing with the contractions, because her natural tendency is going to be push and push hard, okay? So these are different presentations, chin presentations. You can see what's happening here, how the head is transverse and that pelvic opening here. It's just different presentations here, Okay. These are some of your breaches. We'll talk. Here's a shoulder presentation. Here's a brow presentation. Okay. Or this is, I'm sorry, this is a brow presentation. Here's face presentation. Here's your complete breach. Okay. Another one there. Here's a face presentation. You have to look at that for a second to see it. Here's the lips, nose, eyes. Here's a face presentation here. Okay. Here's another one here. Face presentation. Okay. If you got this on the field, you are not delivering. You are going to have the patient pant during the contractions, immediately load and go. Okay. Oxygen, non-rebreather, 15 liters per minute for the mother. Okay. Brow presentation. These are just the different presentations. Now, this is interesting because a brow presentation will spontaneously convert to a vertex or face more than 50% of the cases. If it converts to a vertex, top of the head, deliver. If it converts to the face, you can't deliver. Do not have her push, you can't deliver. Okay. Here's a compound presentation here. Notice the hand, the arm with the head. Compound presentation. If you have a compound presentation in the field, you are going to transport immediately. Do not allow the mother to push. Transport immediately, contact the hospital, get their labor delivery unit, whatever the process you use to notify them, do so. Here's another compound presentation here. You're not going to have this patient push. Okay. All right. Here's another here. Then my all-time favorite. Nope, not that one. Here's another one here. Compound presentation. Here's my all-time favorite here. Like he's gonna beat your ass. This is what your kid's gonna look like, Larry, when it's being delivered. Like, are you my father? Anyways, poor Larry. Okay. All right. Here's a footling. You see this presentation? This is a footling presentation, a foot presentation. Again, what are you going to do? Mother's on non-rebreather, 15 liters per minute. Don't worry about an IV. If you get an IV en route, great. If you can't, that's okay too. This you need to transport as rapidly as possible, okay? Labor delivery unit, labor delivery. You do not do this. You do not try to deliver this. What you're going to do is, again, don't allow her to push during the contraction. Have her pant. Do not allow her to push, okay? So again, this basically is what we just said. You're not going to deliver them. You're going to transport immediately. Contact your medical control. 15 liters non-rebreather. If you have time to start an IV, start one. Large bore. If you don't delay. Do not delay transport to do anything. Do not delay transport. This is one time where you say, look, let's go. Get a non-rebreather on the patient. Let's go. We'll do whatever we can en route. It's more important that you actually expeditiously transport. Don't allow the mother to push, then try to do stuff on the scene, because this patient needs to get into a labor and delivery. Breech presentation is one of the most common malpresentations, about 4% of all deliveries. The main problem with the breech presentation is you don't create a good enough wedge. Let me just ask you this. Have you ever seen a newborn? What do we know about newborns and infants and so forth? You look at them and you're like, damn, their head is huge compared to the rest of their body. That is true. Their heads are disproportionately large compared to the rest of their body. So what happens is when the head is being delivered, what it's doing is it's opening that pelvic opening up, because that is the biggest part of the body of that fetus to move through. So it's a good wedge. But because it's a good wedge, at the same time, it's not allowing anything to fall through, like the umbilical cord. Because it creates a good wedge, nothing gets through. If you don't have a good wedge, what happens? You're on this edge of the wedge, and things can slip by. What's slipping by? The umbilical cord. 3 different types of breech: a frank breech, okay, a complete breech where the legs are crossed, and a footling breech where actually one of the legs is usually presenting. What are we going to do here? We are not going to try to deliver. Non-rebreather, have the mother pant during the contractions, expeditious transport. If you get an IV line en route, good. This one, you're going to see the buttocks. This one, you're going to see the buttocks too, okay? And the other one too is you might have both legs presenting too. A frank breech, 60 to 65% of all breech presentations are frank. And a frank breech is where you're going to see the buttocks first, okay? So this one here, Larry, this baby's not smiling at you in the vaginal canal, okay? That's its butt. The legs are extended. Hip hips are flexed, knees are extended. And the buttocks, though, because it's pretty large in this position, acts like a good wedge. So prolapse cord is only about 0.5% incidence, okay? It's a frank breach. A complete breach, okay, is less common, about 5% of all presentations where the hips and knees are flexed. This is like sitting Indian style. The buttocks are still a pretty good wedge because they're still filling that pelvic opening, but look at the incidence of prolapse cord. The other was 0.5. Now you got a 5 to 6% incidence of prolapse cord. Here's your complete breaches here. And then your incomplete breach is 25 to 35% of all breaches. And there's incomplete hip flexion, single or double footling, okay? Poor wedge, and look at your incidence of prolapse cord, 15 to 18%, okay? Here's your incomplete. Again, if you got a footling, you're not doing anything with this, okay? Nothing. You're transporting immediately. Problem with the breach, it has to be delivered in the hospital due to complications. So here's the thing I'm going to tell you. If it's a breach, if there's any way you could get to the hospital to have this baby delivered, you should get to the hospital to have this baby delivered. If this delivery is imminent and there's nothing you can do but deliver, then go ahead and deliver. If it's a footling, you stop, non-rebreather, have the mother pant, don't let her push, transport immediately. These babies a lot of times are often premature and they need a little bit more resuscitation anyways, okay? Here's a breech delivery here. Sorry, these are a little bit blurry. These are the best photos I could get though. Breech delivery, you see the body's been delivered, the head is still retained, okay? Same thing here. Make sure you support the bodies. Again, they're slippery, they're slick. Make sure you support the body. One of the complications to the breech delivery is you can't deliver the head because remember, the wedge, the good wedge is the head. So the rest of the baby is nowhere near as big as the head. So all of a sudden, when it comes time to deliver the head, the chin and the occiput gets hung up. The chin gets hung up on the symphysis, or on the occiput gets hung up on the symphysis pubis, and the chin gets hung up on the sacrum. And you can't deliver the head. So here's another one where the mother's pushing and pushing and pushing and pushing. You've delivered everything, but you can't deliver the head. The problem is once you've delivered the chest, the baby wants to breathe. But now they can't breathe because her head is still retained within the cervix, okay? Now, this is funny because it's funny. I just went over the NASEMSO clinical guidelines, national clinical guidelines, and they're still saying form this V with fingers inside the vaginal canal. Well, that's bullshit. If the head is in the freaking vaginal canal, you should have delivered it 5 minutes ago. If the head is in the vaginal canal where you can put your fingers in and form a V and feel the nose and the mouth and the eyeballs, there is no reason why you shouldn't have delivered this baby already, okay? In a breech delivery where the head is actually stuck, it's actually stuck behind the symphysis pubis and the sacrum in the cervix or behind the cervix, okay? It's not in the vaginal canal, so that's a useless treatment. Your head is in here. If it was in the vaginal canal, basically one contraction, you should be able to expel that, okay? Here's an unusual breech delivery. Looks like he didn't want to be delivered. He's trying to get back in. Okay, so this was actually published. It was interesting. It was published in the Pre-Hospital Emergency Care journal, referee journal. And it was a group of physicians that actually went through and they actually looked at all the different recommendations, and they found that unplanned vaginal breech delivery, best approach is avoid field delivery. We said if it's not imminent, mother should adamantly encourage not to push while she is transported nearest hospital obstetric delivery. We said that, and it may be necessary to place a gloved hand into the vagina to manually slow delivery. Look what I'm saying. To manually slow delivery, not form a V. But in this case, remember we always saw it. Here again, Matt. Here's another one, Matt. I have to laugh because now I start thinking, well, shit, man, there was a lot of things that taught you that was wrong. And here's another one, Matt. Remember I said, never put your gloved hand inside the vaginal canal except to do what? Form that V in that breech delivery. Well, now what they're saying is actually there's a maneuver called the Zavanelli maneuver. And what you do is you actually try to push the fetus back in the uterus, okay? And you think, well, that's crazy. Well, I say, no, you would never do that. You would never. but that's one thing actually that they would recommend in a breech deliveries. You actually are trying to impede the delivery until they get to the labor delivery unit. Okay. All right. So if it's legs and buttocks only visible, okay, and it's not imminent, okay, tell the patient not to push, transport them, 15 liters non-rebreather, don't delay, don't wait for ALS backup. If you're an EMT crew, you can manage this exactly the same as an AMT crew or a medic crew. Place your hand in the vagina to keep the fetus from delivering. You're going to put your hand in the vagina, push on the buttocks to keep this baby from being delivered, because you don't want the chest to be delivered, because when the chest is delivered, they're going to go through the natural transition, and all of a sudden this baby's going to start suffocating to death. Okay? Take the pressure off the umbilical cord. Placing the hand in the vagina to take pressure off the umbilical cord is not effective too, because usually the cord is between the head and the pelvic opening, and that's where it's being actually squeezed there. And consider tocolysis. One thing that they recommend in their article is nitroglycerin. So I don't know. That's an off-label use, though. FDA has not approved nitroglycerin for tocolytic. It's like terbutaline was a very common one, and terbutaline's an off-label use too, where FDA didn't approve it. One thing in EMS too that we carry is mag sulfate can be used as a tocolytic because of the smooth muscle dilation, reduction of smooth muscle contraction. If delivery is imminent and inevitable, well, and if you got the legs and the buttocks, you know, if the buttocks are there or both legs, if it's one leg, not going to deliver. Tell the mother push hard, okay? And they say, now, these maneuvers, I'm not going to expect you to memorize these because, like, to be honest with you, I don't have memorized either. But all I'm going to say is if you're on the phone and you have maybe an obstetrician on there, they may be actually walking you through these maneuvers. And I'm telling you, get on the phone if you need to. But the Pinard maneuver is, look, these are maneuvers that you're going to do in order to try to deliver. If your transport time is like an hour out, I know some of you have some long transport times up in Trumbull County, you know, in the far reaches, maybe you're up in, you know, some of these areas, you know, they may be instructing you on how to do this, like this Pinard maneuver, okay? You're going to follow these instructions, but this is what they're recommending. This is how you deliver a breech, not, you don't form a V, you know, with your hand in the vaginal opening, okay? If delivery is imminent and inevitable, and it's a frank breech where the buttocks are first, sweep the legs, okay, to deliver them, rotate the fetus to the back anterior occipital position, apply suprapubic pressure, and they perform this Marcio maneuver. And here again, these are these different maneuvers that are performed. And again, I'm telling you, I don't know, I don't know if you could tell us, Larry, when you get in your emergency residency program that, whether you learn these or not, I don't know. I don't know if that's something that an emergency medicine physician would even do, but a labor delivery physician obviously would. So if the head is entrapped, rapid transport, do not allow the mother to push. Don't let her push. Non-rebreather, 15 liters per minute. Notify the receiving hospital. Attempt to manually push the cervix over the fetal head. That means you're going to take your hand, okay, and you're going to stick your hand in the vaginal opening. You're going to feel the cervix, and you're going to try to push the lip of that cervix over the head of the fetus, okay? So remember, the neck is here. The body's delivered. You're supporting the body, the neck. You're going to go in and try to get the lip of that cervix off over the head. And then consider the Zavanelli maneuver.
My best calling card. That's why we fought. I didn't want to.
The Zavanelli maneuver, this consists of replacing the born fetal parts into the uterus and transporting the patient to a facility where emergent cesarean section can be accomplished, okay? You actually are pushing them back in the vaginal opening. Don't do this on your own. Matt's probably sitting there cringing. Don't do this on your own. Get on the radio, get on the phone. You guys are using phones now. Talk to it, and if an OBGYN emergency medicine doc tells you this is what you need to do, or they say the Zavanelli maneuver, this is what it means. You're going to attempt to actually restrict that delivery. Do not allow the mother to push. Prolapse umbilical cord, okay, it's when the umbilical cord is the presenting part, okay, and this often occurs when it's a breech delivery or it's a low birth weight baby because they don't have enough mass to take up that space. They don't fill that complete space. Malpresentation is 50% of the cord prolapse. Prolapse cord occurs in 0.3 to 0.6 of all deliveries. So it's enough. Okay. Here's a prolapse cord here. Okay. Here's a prolapse cord here. Okay. And the danger of this is, remember, before this chest is born, this baby is relying solely on that placenta for all its oxygenation, elimination of CO2, waste, everything. And if we compress that cord, basically it's no different than you strangulating the baby. Okay. Again, here's a cord here. And the problem here is, if you notice this cord's coming down here, it's being compressed by the head of the baby. Okay. So emergency care for a prolapse cord, non-rebreather, 15 liters per minute. Place the patient in knee chest position, because again, it opens up that pelvis a little bit. Put the cot in a Trendelenburg position. You're going to try to use gravity to your advantage. Lift the presenting part off the cord. Whatever the presenting part is, take your hand, put it in the vaginal opening, and try to lift the presenting part off the cord so the cord still will be able to pulsate and deliver, circulation to the baby. Cover the cord with a moist sterile dressing. Yeah, that's great if you have time to do that. That's not your highest priority. Rapid transport. This is another complete emergency. This is another one where you should actually expeditiously transport the patient. Here's your knee chest position. Try to use gravity to your advantage to actually have the baby pull back down into the uterine opening, or uterus to take pressure off the cord. Okay, same thing here. Relieve pressure off the cord. Okay, nuchal cord. We already saw that one presentation. Here's the cord wrapped around the neck. Okay, so what's one of the first things you're going to do when you deliver the head? We're saying it's a normal delivery. The head is delivered. Remember again, here again, Matt, we should beat into your head. As soon as that baby's head is bored, what are you going to do? You're going to suction. Suction nose, suction the mouth. Suction nose, suction mouth. And when you think you suction enough, you're going to suction again. And then, if the baby opens the eye, suction. If the baby farts, suction. If your partner farts, suction. It's like you suction on everything. Everything you did, you suction. Well, we're not doing that anymore. Routine suctioning is no longer recommended for newborns. You're only going to suction if there's an obstruction to breathing in the newborn. So one of the first things you're going to do actually is you're going to check for a nuchal cord. As soon as the head is delivered, you're going to take your hands, you're going to run around the neck, and you're going to check for a nuchal cord. Look at this one. This is a pretty significant nuchal cord. And the first thing you're going to do is you're going to attempt to take the cord, and you're going to attempt to either slip it over the shoulders, back down over the body, or you're going to attempt to take the cord over the head. If you can't do it, then what you're going to do is you're going to clamp the cord in two places. It doesn't matter where. You're going to clamp the cord, but make sure those clamps are tight. Clamp the cord, and you're going to then cut between the cord, and you're going to continue with the delivery at that point. Once you've clamped and cut that cord, you now have shut off the circulation to that baby. Keep that in mind. So you better progress pretty rapidly with the rest of the delivery of the baby. Okay. And these are just tocolytics here again. Probably, the nitroglycerin or the mag sulfate. You guys are saying you're not carrying the nicardipine or nicardipine. Terbutaline, again, they're really not using any longer as, tocolytics for its beta 2 effects, so forth, calcium channel blocker. And anyways, you're not carrying prostaglandin inhibitors. Okay. Any questions? Oh, shoot. 7:35. Sorry. Any questions? Anything? Nothing? Nobody? All right, Matt, Larry. You guys still there?
Yeah, Matt's getting his stuff pulled up.
How about hell? Have I been talking for the last half hour? No, I'm not even on. All right.
He really wasn't expecting you to shut up until like 10 till, so.
Thanks, Larry. I knew I could count on you, buddy. I knew it. All right. Okay. If anybody has questions, again, you got my email address. Larry, if I didn't have, I can't remember if I put this on my Google Drive or not. I don't think I did, but I'll do it before we get off tonight. Okay.
Okay, no worries.
I'll get you questions too, probably by tomorrow. Okay.
Thank you.
Okay. If anybody got questions, I'll be, on obviously for the rest of this too. So let me know.
All right. Hi there, everybody. If does anybody need a break? We need to take a 5-minute break or anything, or we all good? Nothing. All right. I'll take your silence as compliance. Today, I'm just going to take a little bit of time and go over the opioid problem. I'm going to take a little bit of a different tact on this. I'm not going to go through every darn medication, every darn drug, and everything we go through. I'm going to address the elephant in the room, the opioid problem that we've been dealing with for the last several years. In my career, I worked a lot in East Liverpool, I worked a lot in Youngstown, and I worked a lot in Warren. And we always had like heroin waves. And it seems like it'd be bad for a year or for 2 summers or something, and then kind of wane off again. It would wax and wane. This particular, I can't even call this a wave of opioid abuse. This is, unfortunately, it's the new norm, and I hate that term too, but it's the new norm, and we deal with it constantly. We deal with it every single day, literally every single day. It used to be back in the day when someone gave Narcan and we gave 0.8 milligrams of Narcan, you were like, whoa, that was, that's crazy. You had to give 0.4 again. And now, I'm not surprising anybody by, how much Narcan we give people sometimes. And we might address that too in discussion, how much Narcan we're giving people. So addiction and substance use disorders are many things, and some of those things are that they're preventable. This is a absolutely preventable health problem. We can prevent it through education. We can prevent it through treatment. All these other things. It is treatable. People do get better. Recovery is possible from this. I'm not gonna be that guy and pretend that everybody gets better, because that's not the truth. But some people do, and it's our job to make sure that we keep them alive so that they have that chance to recover. So, addiction is a brain disease. Whether people like to, politically or anything like to say that or not, its definition: addiction is a chronic, relapsing brain disease that is characterized by compulsive drug seeking and use, despite the harmful consequences. It is considered a brain disease because the drugs change the brain. They change its structure and they change how it works. Go back to that a little bit. It changes the brain. It actually changes the physical look, the physical operation of the brain. So the AMA says addiction has the 3 elements that define any disease, and that's symptoms, progression, and prognosis. It is chronic. It doesn't get better, but it is treatable. So what are the risk factors for substance abuse disorder? Well, a lot of the same usual things we see on a lot of other social issues. Victims of abuse, easy availability, a poor self-concept, difficulties coping, weak family relationships, early experimentation, behavior issues, and genetics. Genetics is one of the biggest driving forces for addiction. It's not that you hang out with the wrong crowd. It's not that you know what I mean, you're just this partying guy or anything. Genetics and all these things have a lot to do with it. And just like other diseases, there's certain things that put us at risk. One of the biggest predictors also is early experimentation. Because your brains are still developing, your brain is more vulnerable to the negative effects of the drugs. Damage to your brain can happen quicker and can be more severe than with the adult brain. And your brains can get addicted to substances much faster than the adult brain. Having said that, someone can have all of these things, can have hit every single one of these marks and not end up an addict. And someone can have none of these marks and still end up an addict. It's a fickle beast. The United States, we have 5% of the world's population. We use 80% of the world's opioid painkillers and 99% of the world's Vicodin. That's amazing to me. I guess it is, but it isn't. I wish it was more amazing than it is. That's enough. That's enough painkillers for every adult in America to have a bottle. It's enough prescriptions for every man, woman, and child on to be on painkillers for 24 hours a day for 1 month. %67 of all heroin users misuse prescription painkillers first. Folks, we've seen this story. We've had this story in the back of our ambulance 100 times, have we not? The person gets painkillers, runs out of painkillers, steals them from their house, steals them from their neighbor, ends up buying on the street, and before you know it, that's where we're at. Does everybody do that? No, but looking at this, 67% of the heroin, we're going to say heroin, but it's opioid users, misuse prescription painkillers in the first place. The average prescription painkiller on the street goes for about $1 a milligram. So an 80 milligram Percocet would be $80. A bundle of heroin is usually around $10. So why does heroin feel so good? Why do these opiates feel so good for people? Well, food takes to about 100, sex about 150, nicotine a little more, cocaine approaching that 250. Look where heroin is. Heroin takes us to a level 2200. What's the problem with that? Well, it feels really good, and that anything that feels good, being the animals we are, we're going to go get more, for one thing. But the biggest problem is that your brain can't handle that much dopamine, and so it adapts. And how does it adapt? It adapts by stopping making its own dopamine. It depends on outside. Oh, I hope this cough starts back up. Excuse me. Your body then depends on outside sources of dopamine. So then when that dopamine doesn't come from your last fix, that's when we get these behaviors. So we need dopamine, and during recovery, the brain is healing, and relapse happens in recovery because you crave that dopamine release so badly, and your body is just simply not making it. So why do people use opioids? Well, usually if you see at the start of this graph, the squiggly line, they start off as a normal person, and the first time they do it to get high, to have a good time, to forget something, or whatever their reason is. So over the time, you can see as that line starts to dwindle closer towards the center, they spend for you. And then before too long, they're taking that heroin or that opioid just to keep themselves in the normal range. They've entered tolerance and physical dependence. The longer it goes on, the more dependent they get. They have to take these meds, these drugs, to just stay in the normal range, to just operate on a day-to-day basis. They're no longer doing opioids to get high. They're doing opioids to stay well. So what are the risk factors for an overdose? Well, there's a lot of different risk factors for overdose. One of them being a previous overdose. If you've overdosed before, we all have those patients that when you wake them up, they know your name. And that's sad, man. That's really, really sad. Obviously, a history of substance abuse or misuse, previous suicide attempts, access to the drugs, witnessed a family member overdose. Now, I don't know if that's because the genetic portion of that, or because they watched it and, it makes some sort of scar or whatever, or maybe almost normalizes it. When kids are raised in a certain environment, when they think that's normal, that's what they expect from their parents, and that's what they think is normal. Or high prescription opioid doses and or sustained action. You see less of the high opioid doses anymore. Hopefully a lot of the physicians and stuff have gotten much more responsible than they were many years ago. So let's hope that that's on its way down. What about acutely? None of this is going to be a surprise to you either. Acutely, periods of abstinence. How many overdoses do we get the day they get out of jail? You know, they've been incarcerated for even 10 days. They've been incarcerated for 10 days and they come out and they think they're going to do the same amount they did before they got in. Their buddies are probably, hey, let's get together and party. And then there we are. We find them deceased or overdosed. A change in the amount of purity. We always say, you know, when you get a rash of overdoses on a particular side of town, oh, dope man must have some good stuff today. I always thought it was funny in the media when they would put out that, hey, there's bad heroin going around. If you know anything about heroin overdoses or heroin addicts, when you tell them that there's bad heroin going around, they're going to go looking for it, because bad means good. Bad means it's very strong. And hopefully then they can taper the amount they do. But, you know, oftentimes that ends up in an overdose. Injecting, that sounds obvious, but a lot of people start out with opioids, you know, by snorting or by taking pills or whatever, and then graduate to injecting. Mixing opioids with other substances, whether on purpose or by mistake, or that's how you were sold. We'll touch on something a little later about the purity of anything on the street these days. Especially other CNS depressants, you know, some benzos and opioids, that's a bad thing. Using alone, another thing of the deaths, we're going to look at some statistics from Trumbull County here towards the end of this. 3 of those people that you're going to see that are on our deaths, 3 of them had Narcan in their pocket or in their purse when they were found dead in their home or hotel or wherever they were found. Being physically ill or having a respiratory disease. You know, this person uses heroin every day, but now they've got bronchitis, but they're still dope sick. They do that. The respiratory disease combined with the opioid is just enough to suppress that respiratory drive. And anyone who's been homeless in the past 90 days. I think when you approach homelessness because of your drug problem, you are probably at the rock bottom, and we're going to see those folks. So something I'd like to talk about is risk compensation. And here, this is something that a lot of people over the years, myself included, and I'm sure a lot of other people, we think that if we supply Narcan for these folks, well, they're just going to get high, and because they know they have a safety net. And history shows us that that's just simply not true. Those who receive naloxone rescue kits as part of one particular program had higher rates of calling 911, higher rates of administering the naloxone, and higher rates of staying with the victim while help came. It reduces overdose at a population level and increases preparedness to respond effectively. Levels of use do not change. In other words, just because you have Narcan in your house doesn't mean you're going to do any more or any less. It's other things. It's other parts of the equation that are going to help you take or not take or recover as best you can. And we also know this from some familiar things throughout the past. Safe sex education. You know, when I was a kid, we started having we didn't start having sex education, but sex education was a big thing in school. And one of the worries was, I went to Catholic school, so we didn't have sex education like other folks. But one of the big worries was that, oh my God, these teenagers, you're teaching them how to have sex. These teenagers are going to go out and just have sex all over the place. Not true. HIV prophylaxis. Look at all the things we did when HIV was around to educate. We were giving out condoms. We were doing all these things. That didn't change. It didn't change the behavior. Needle exchange. You would think that needle exchange with the heroin epidemic would make people do more heroin. It doesn't. It doesn't. It makes less hepatitis B, which is good for EMS providers. Seatbelt laws, helmet laws, you know, all these things we thought that were going to be, you know, going to make people less risky and everything. That it's simply not the case. There is a cost versus benefit. The cost is worth the benefit in this particular case, in that our goal is to keep people alive. This is not a political statement. This isn't anything along those lines. Our goal is to keep people alive. That's your job as EMS providers, not to judge. So we all know the signs and symptoms of opioid overdose. We've been to a few. Slower absent breathing, cyanotic, not moving, gurgling sounds, tiny pupils. We all know that, to the point that we can pretty much walk into a room these days and be like, that's an overdose. So keep it simple: depressed mental status or coma, ineffective or absent breathing and pinpoint pupils, and a reasonable suspicion. So when we go to give Narcan intranasally, and you know that's a big deal for us now. I think that was one of the better things we've come up with in the last several years in my EMS career, is the intranasal meds. It does help keep us safer, folks. We don't have to get a needle out. We don't have to do these things. But we have to understand that one of the reasons it does keep us a little bit safer is it has a little slower onset. We have to be patient. We have to be patient. We have to give this medication a chance to work. But while we're waiting around for the medicine to work, let's not stand around and stare at the guy. We should be ventilating these people. We should be supporting them. And if they don't need ventilatory support, they probably don't need Narcan. You know, it's okay. It's okay sometimes to not turn these people into walkie-talkies. You're creating your own problems. You know, a lot of the talk I hear is that, wow, we woke this guy up and he came up fighting and everything else. Well, you gave him 12 milligrams of Narcan in 2-minute intervals. Yeah, that's what you're going to get. So be patient. This isn't going to be a whole talk on Narcan administration, but be patient. It's a little frustrating sometimes when care facilities and or the PD just keeps dumping that Narcan, but understand how they're trained. They're trained more or less to keep doing it until they get up. Does that cause us some problems? Yeah, because by the time PD and the facility that they're at ends up giving them, you know, however many doses up the nose, they're wide awake and mad sometimes by the time we get there. So just be careful. You know, consider Narcan a respiratory drug. We want to get that respiratory rate up. We want to get that tidal volume up. We want to get them breathing and everything. But if we can leave them a little bit somnolent, maybe we don't need to be given, you know, 4, 6, 8 at a time. Maybe we need to be a little more patient and control that airway for the patient. If the first dose doesn't work, you can administer a second dose, 2 to 5 minutes to take effect. Narcan stays in the system about 1 hour and has a shorter half-life than heroin. So someone can go back into overdose after Narcan wears off. There's another side to that coin. We sign them off, you know, absolutely appropriately, sign them off and leave, and they go do the rest of their heroin that they had left because, you know, we just took away their buzz, we just took away their fix. And you know, that coincides with the half-life of Narcan, and we end up with a dead patient. So I'm not telling you to not sign people off or anything along those lines. What I'm telling you is to be careful and treat these folks as the human beings that they are, and have some empathy and concern, and do a good job. Excuse me. Be prepared. You know, 50% of the administrations result in no negative side effects. So I guess that's good and bad. Half the people don't cause you any problems or anything, but half of them might. So naloxone can precipitate the withdrawals, and these may manifest as anger or irritability. We see that a lot. Dope sick, we see that a lot. We might be able to help on the dope sick thing by not dumping so much Narcan into them if it's in our control. Vomiting. Vomiting is a lot of times from pushing too fast. I'm sorry, excuse me. Combative, about 4%, and other, about 5%. Guys, we have to realize that the initial reactions when these people come out of this are medical. These aren't criminal actions. These aren't people that are assaulting you because of you. They're assaulting you because of the situation. Just for the record, I did not cough all dang day, but now here I am. Always use our universal precautions. So what are some fentanyl myths? Coming in contact with even a small amount of fentanyl can cause an overdose. I know this was a hot button topic a little while ago, and actually an officer that I was an acquaintance with, had an episode that was on the news, and that was way back when, before we were well educated. Guys, it doesn't happen. I hate to say it, those are psychosomatic issues. Those are not overdose issues. I would like to see all the people, and I'm not picking on police officers by any stretch, but all the people who have experienced this overdose, I'd like to see their tox screen and see what was in their bodies. It's a myth that there are some forms of fentanyl that are resistant to naloxone. And it's a myth that there's no problem with first responders being overly cautious around fentanyl. So why are these? Well, coming in contact with a bag or a little bit of dust in the room is not enough to harm you. Powdered fentanyl does not penetrate the skin very easily. Naloxone counteracts all opioids. Does it sometimes take more for certain kinds than others? Of course it does, but it works on every single opioid. And the problem with being overly cautious is, we're taking so much time to be safe and everything that the patient is laying over there dying. While we're setting up command and getting dressed with all the appropriate PPE or maybe inappropriate PPE that we think we need, that person is still laying there not breathing. If you touch fentanyl, it can be removed from the skin with soap and water. Alcohol-based products shouldn't really be used. It might increase fentanyl absorption. You need to wash your hands soon, but not necessarily immediately. Although, and I wouldn't lick my fingers or rub my eyes or anything if I could avoid that. There's no real need for special gear or double gloving. Unless you're in an environment, say there's been an explosion at a meth lab or something along those lines. That's not really an EMS issue at that point. That's probably going to be a fire department and hazmat issue. And hopefully they're bringing you, the patient, into the warm zone or into the cool zone after decontamination. We should all be wearing masks on every single patient anyway. At this point, there's not one person on this talk that should be going to any house on any EMS call not wearing a mask, not at least wearing a surgical mask and probably an N95. Although follow your local protocols and your local policies. So what happens after we give Narcan? Well, we don't want to be part of the problem. Anybody who's ever rode with me or worked with me or anything else knows that rule number one of Mac Gordon and EMS is we don't make it worse. We have no business making it worse. So we have to be careful what we say to these folks, guys. They're in a fragile state. I know it's frustrating. I know we're fatigued with this. We have what's called compassion fatigue, that we're just like, oh my God, not again. But remember, we need to avoid that shame. We need to avoid that guilt and that stigma. So be careful what you say. And they hear you. They hear you. So what should we say? We need to be more tolerant. We need to offer a little bit of hope and be supportive and compassionate. We're part of the solution, folks. We don't have any business being part of the problem. We are only part of the solution. So we need to remember that this isn't a moral issue or a matter of what's right or wrong, or it's not even a matter of what you think or what your opinion is. We're not at that point. We're at the point where this is a medical issue. Our job is to save lives, to improve lives, and that's what we're here for. So what should you say? Let them know that there's treatment available and people do find recovery. There are stories out there I have a person that I'm thinking about right now who is in my family who you wouldn't even believe her story from the beginning. And the fact that she has recovered and is a valuable and productive member of society is amazing. If I had the time to tell you her whole story, I would. It's amazing. And there are resources and there's people to help. We are resources. We are people that help. It's your job. It's what you're doing. It's your calling. Even when it's hard, we still have to do that. We should find out if there's someone we should call for them. And we should let them know, because you're going to experience some withdrawal, that this is a time when people often want to use even more. And that's why it's important to try and get these folks help at this point where they're very, very vulnerable. So what are the options? Medication-assisted treatment is the most effective in reducing overdose deaths. There's inpatient treatment facilities. They work too, but we all go on EMS calls to inpatient treatment facilities, don't we? They still manage to sometimes get those drugs. Intensive inpatient, outpatient treatment programs. There's holistic nutritional alternative approaches and community support. I don't know how the holistic things work or anything like that, but I imagine a combination if these people need to help find something that helps pull them out of this. And if it's holistic and community support and out treatment patient and medication assisted treatment, then that's what they should have. So I'm going to give Trumbull County a little bit of home cooking today. One of the boards I'm on is the overdose board with Trumbull County Combined Health District and the Warren City Health Department. And I'm not going to go over every single thing in here, but there's a few things that should be pointed out. Last year, 590 reported overdoses. The bulk of those being in the age group of 31 to 40, which isn't any surprise. Over on the right side here, Saturday's the biggest day. Wednesday, Friday, Saturday, Tuesday. Wait, all the days, huh? There's not that much of a difference. Monday or Thursday seem to be your best days for not having overdoses. August was our highest month of reported overdoses. So, Saturday nights on August with a 31 to 40-year-old male are pretty much your biggest bet. Now, again, this is in Trumbull County, and this was 11 deaths. I believe it was the month of November I picked these from. Out of 11 deaths, 10 are white, 1 was black. The biggest was the 35 to 44. Come on. I want this to go back. Sorry about that. What about health issues? Of the 11 people, 4 had documented physical health issues. 1 had mental health issues. 3 had both. 1 had sensory issues, and only 2 had no documented health issues. The death investigations, 6 of them took place at the home. The next highest was 2 at a friend's home, 1 at a hotel, 1 at the hospital. What about their employment? Most of them, it's unknown, I guess. 1 full-time, part-time unknown, 1 homemaker. So unemployed for the most part seems to be a big deal. You would think that down here on the other corner that the criminal history would be revealing, but it's not. 8 out of 11 of these people that died in November had no criminal history whatsoever. If you look over here, see any heroin overdoses? You see heroin even mentioned? Not even mentioned, not even in there. Most of our overdoses are multi-drug overdoses, with fentanyl and cocaine being the lead. And this is where I'd like to touch on a little bit. This is where these multi-pharmaceutical overdoses. This is one of the places where you might want to be careful. You might want to start thinking about what you're doing with your Narcan. If you think that, if you're one of the people that think that slamming Narcan in is funny, that fentanyl that is masking the cocaine or the PCP, you're going to wake the beast. So now you take that fentanyl away that was the only thing that was sedating this patient, and now you've got a guy that's high on PCP. So what do we do then? Then we have to tackle this guy to the ground, wrestle him around, and we end up sedating him and putting him on a vent. Right? Right? It's bad medicine. It's bad medicine. Start thinking about what you're doing with your overdoses, please. If you look at our total overdoses, this is something that was very telling in this meeting the other day. In 2021, we had 590 reported overdoses. And I'm just going to go back to 2020, where we had 879. So in 2020, through November 23rd, which is when I had these stats. So even though in 2020 we had 879 reported overdoses, we only had 90 deaths. In 2021, we had almost 300 less reported overdoses and 9 more deaths in the same period. So what's that tell us? Does that tell us that there's stronger drugs? Does this tell us that there's less reporting? Does this tell us that people who are giving Narcan aren't reporting or anything like that? It might be telling us all of those things. What I'm telling you is this 590 in 2021, and people pointing at that and say, oh, look, heroin use is going down. I'm going to go down here and tell you the heck it is. The heck it is. How many people had previous ODs? We know for a fact we had 3 previous ODs. One had no previous OD, and 7 of them were unknown. So medical assisted therapy of the overdoses, 2 on Suboxone. Formal treatment, 2 had formal treatment, 9 had no formal treatment. And you can see that 4 of them had mental health issues. So what does formal treatment versus no formal treatment tell us? Well, maybe, and this is speculation, maybe we're doing a good job with the formal treatment because we only have 2 overdoses over there, and we have 9 on the ones that haven't been treated. And finally, this is a chart. I want you all to read this real quick. This is just a chart. This is a flyer that's been put out by Trumbull County Combined Health District about counterfeit drugs. And the pills that are being bought on the street, none of them are what they say they are. They are all counterfeit. And they're all fentanyl, or fentanyl and methamphetamine, or some sort of mixture along those lines. People who think that their drug dealer cares about them, your drug dealer doesn't care about you. Your drug dealer is going to sell you whatever they have to make that $10 off of you. There's a lot of different programs out there to try and get Narcan out into the public. One of the things we're trying to work on right now here in Trumbull is that if you come in with an overdose, you're going to leave with Narcan kits. You would think that that's a really easy thing to get done. But it's not. There's so much red tape to jump through, but we're very close to that. And a lot of places, EMS, EMS, when they leave an overdose that's a legitimate sign off, they leave another kit with them. To my Trumbull County, to my TMH people that are protocoled under us, we do not leave our Narcan with anybody else. Those drugs are signed out to you. Those medications are signed out to you, and you are responsible for them. We do not distribute. Although we are looking at distributing on these particular calls through Project Dawn. So in closing, folks, I just want to say, I know that everybody is very, very fatigued with the whole opioids and everything else, and it's very easy to look down on people. Understand that They're human beings. We are there for human beings. We are there to save and preserve life. We are not there to judge. We're not there to admonish or yell at these people. You know, it's important that we treat them like human beings with empathy and compassion, so that they're not afraid to call for help. We want these people to call for help. And I'll bet right now there's some people that in the back of your mind, you're thinking, no, I don't. But I'm going to put a little face on it. If that was my daughter laying on the ground, and my daughter is like one of the nicest, clean cut, straight edge kids you ever saw. But if that was my daughter laying on the ground and that was the 5th time that you'd come to revive her, I still want you to revive her. Hope is hopefully right around the corner for some of these people. I implore you to act with compassion, act with empathy, and act professionally and do your job. And that's all I've got for you. Does anybody have any questions? I'm sorry I went a little bit over. Questions, comments, concerns?
Matt, it's Tom. I just have a statement to make for everybody. So I've been attending the mental health and recovery board meetings the past several months. So make sure that you guys, for these people that legitimately need help and don't know where to go, or have families or jobs and stuff that they still have to go to, that can't necessarily go to inpatient, make sure that you're giving them the contact for the mental health and recovery board or Brightview as an outpatient service. The mental health and recovery board has a plethora of resources and stuff for these people to use, and access to treatments and stuff, helping them get health insurance, helping them get their driver's license, helping them do so much stuff. So make sure that you guys are giving those numbers out. They have the money, they have the resources. Use them as we can.
Good point, Tom. And the mental health and recovery board, they're a bunch of angels. They're really amazing people. I will get those numbers out to everybody. I didn't see any direct studies about the passive absorption, but just like anything else, intact skin is it's pretty hard for powdered fentanyl to absorb through the skin. I imagine, you know, if somebody took a handful of it and blew it right in your face, that might be a problem, or in your mouth or something along those lines. But no, there has not been. I haven't come up with anything that shows definitively, you know, what the rate of absorption is. But again, I would love to see the tox screens on. And again, I'm not picking on police officers, but they're the ones that have been in the news. I'd like to see the tox screens on these police officers who had issues at a scene to you know, to see, you know, what happened there. I don't think you're going to find that it's fentanyl.
Matt, can you hear me?
Yes.
Yeah, this is Steve Mock. There's a Pittsburgh doc, Jason Kodat. He had a compilation of every case that he could find across the U.S. There was hundreds of them, and I believe of that there was one that had come back with a positive tox screen. Everything else was showing up negative, or they didn't have a tox screen. So, like I said, I mean, they're not running them. It's like you said, it's all the psychosomatic responses and everything. But yeah, I mean, there's a lot of people who are, like say, actively looking for those things, and they're just not done.
Gotcha. And I know that you and I have talked about this before, Steve. Thank you.
Oh yeah.
Hey Matt, it's Nick Graff. I got a story to add to that. I know of a incident that happened at a different hospital, not Trumbull, but all the symptoms that came back from this mysterious white substance that caused nurses to pass out were tachycardia, hyperventilation, and hypertension. So nothing that's even make sense to an overdose. But no blood work was run, but those were the symptoms from the people in the room that supposedly overdosed.
Huh. That's interesting. Yeah, but you have to wonder why weren't tox screens done? Like if personally, if I was in a hospital ER or running the hospital ER and a police officer came in and that was our suspicion, I mean, we'd be doing a tox screen, right?
That one I don't have the answer for, but I do know was when I was working for the hospital, and obviously we had these discussion about this, and that was the symptoms that were given. I don't know why they didn't do a blood screen, if otherwise just assume that this was hysteria and not an overdose.
Wow. Right. Well, thanks, Nick. I appreciate that. All right. Anybody else? All right. Well, I ate up a little bit of Larry's time, so I'm gonna send it over to Dr. Larry. Thank you so much for your attention, everybody. And I ask that you please take some of the things I said to heart. Have a good night. Second.
Eric Metz, do you have a question? Saw your hand go up. No? Okay. All right, so Joe said I never draw many pictures, and I use his long-winded lecture to draw him a picture. And if you can see this, that's Joe. I'm going to call him Grandpa Joe. And actually, let me wait till Matt stops sharing his screen here. Yeah, next to leave, hit the X. Nope. Nope, the other one. Give us a second. All right, to the left of the phone. There you go. All right, so this is my cartoon, my sticker for Joe, and I even wrote Joe on there because I thought my script handwriting would not be good enough to make his wall. So, but Joe, you're an all-star in my book, and thanks for your contribution to EMS. And for those of you who are on this, like, why does Joe and Larry pick on each other? It goes way back to paramedic school, and we've become good friends and colleagues since. I'm going to talk about pre-hospital pain management here, and we are going to run over just because of the time and everything, but just bear with us, and I think you'll find some stuff interesting. So let's get out of here. So we're going to talk about pre-hospital pain recognition and assessment. We're going to talk about some of the pain assessment scores or scales, both for adults and for pediatrics. We're going to talk about pharmacologic and non-pharmacologic pain options, and then kind of talk about some safety risk aspects of pain management, and then what's key to documentation and why we require you, or those of us who do QA, it's like, hey, I need to know what their pain scale was. So again, this is most of this lecture is from the National Association of State EMS Officials, and SEMSO, that you've heard Joe mention throughout his lectures. And then also this is from a colleague of mine down in University of Florida, Jacksonville. They have a pain assessment and management initiative that they're trying to push across the country, and they take feedback from EMS and other ER emergency departments to talk about what they've done and what works well. And then in there, you'll see some what the NASEMSO guidelines are and what the states are guiding the national EMS guidelines to be here. So, I think all of us, we get called to those patients who, are complaining of abdominal pain, or they're complaining of, a fracture or sports injury. And some of us don't make the decision to give pain medication. But, I think that one of the things we can do is make our patients comfortable. And I think it's one of the key priorities I think we need to do. So timely management of pain administration is great, right? And that's one of the first encounters that somebody might have with EMS is, man, that that EMS crew from XYZ fire department or that ambulance company, they really did a nice job, and I wasn't in any pain. So that not only goes forward to their first initial experience with EMS, but also moving forward down the road. Now, if that's a community-based department, you're going to want to get levies, and they're going to think nothing but good things about you, right? Not only the patient, but also the family as well is going to have a good experience with EMS if we treat the pain, moving forward. And then, children, think about this. When you were a child, how did you get sensitized to a needle? How did you get scared of a needle? You got scared of a needle because somebody kind of forced your arm. They came at you with this needle and they gave you a shot. But prior to getting that injection, you didn't know what a needle was, right? So how we train the brain or condition these children will have long-term effects. And people who have they're scared of needles or they almost pass out when they have blood, that can go all the way back to when they were a child and how they received their first injection or the first blood draw. So it's important for us to kind of have some compassion and empathy, as Matt was talking about, but also to, do what's right for the patient. Pain is the most common reason for seeking healthcare and usually accounts for about 78% of all ER visits. And that's more than for Americans than diabetes, cancer, and heart disease combined, right? That's one of the reasons why people call 911. And then, when you do studies, you find that 30% of EMS transports, they usually have moderate to severe pain, but only 1 to 2 patients get pain relief prior to going to the ER. So we're not doing an effective job at treating pain. And then in 1999, the National Highway Transportation Safety Administration, they did an outcome and they found out that pain relief is one of the most important outcomes for pre-hospital satisfaction scores, or how EMS is doing. And so I think today more so than in the past, but we know that ER offload times for patients have gone significantly up, and that's due to either overcrowding, staff shortages, a lot of people just being done with healthcare. But think about that. Before the pandemic, we might have waited in triage for maybe 20 minutes and that patient was waiting to be seen. But then when may have you given that pain medicine in the back of the ambulance? Was it as soon as you started rolling? Was it before you moved? The average transport distance time to the hospital, maybe it's 10, 15 minutes. And some of these narcotics were off in that time. But now you're in the triage line and now you're not getting triaged right away. And then when you do get into a room, the nurses and the healthcare staff are busy. And then there's usually, 1 nurse for 6 patients and 1 doc in a mid-level for the whole ER of, maybe 60 patients. So do you think that patient is going to get the adequate pain relief that they get in the ER? So probably not. Not say it doesn't happen, but us in EMS, we can actually facilitate that and start to get the pain meds on board and redose if we need to in order to provide pain relief for the patient. So studies have showed prior to the pandemic that the facilities waited up to 90 minutes to even give a pain medication to some of these patients here, right? And then we know that if the patients kind of calm and their pain is relieved, that goes better for the charge nurse, that goes better for the doctor. Things will be a lot easier for the patient to kind of get in and get out. We all know, those healthcare providers have had a bad day, a bad week, busy night, and then you get somebody who's in pain and they're agony and they're kind of crying, just give me something for pain. And then what does that do to those providers who are taking over that patient? They start to get frustrated, right? So EMS plays a huge role in that. So, pain can be linked to post-traumatic stress disorder. We talked a little bit about conditioning in children, so one event leads to the other. And then, taking care of acute pain is important because we can prevent chronic pain by not hypersensitizing the pain pathways in these patients. But, I think EMS has a lot of barriers and a lot of myths. And I think that's one of the reasons why we don't give good pain medication or pain relief in the pre-hospital setting. Some people think that I have more important things to do in the back of the ambulance. Well, you assess your patients, you do your physical exam, and you figure out what you need to be done. And pain is one of those vital signs that you need to address. Would you address a heart rate of 30? You probably would. But at the same time, you should address the pain if it's moderate or severe. You should address that with just the same amount of importance as you do the heart rate of 30. Another thing is, I can't get an IV in this patient. Well, let me tell you what, that excuse, can go out the door, because we can give pain medications IV, intranasally, orally, intramuscularly. We can nebulize pain medication. And then some people are like, oh, you spent 20 minutes on scene at the house, and you got to get going to the hospital. I can't have these long on scene times. But again, you're there for that patient, right? It's going to take maybe 5 minutes to get that pain medication on board for that patient, and then make them comfortable for transport, and then figure out what's going on with the patient. Another myth or another barrier is a short transport time. Hey, I could be at the hospital in 10 minutes. But again, you don't take into consideration the amount of time that the patient is at the hospital before they actually get assessed and get pain relief. People are like, oh, I don't want to give this drug because I don't want their blood pressure to drop, or I don't want them to get the rigid chest. Or maybe, this patient is just seeking. Well, studies show that if they're complaining of pain, they probably have pain, and it's better to treat the pain than not treat the pain, right? Dosing concerns, that's another barrier. Like, oh, I have a kid here. I don't know if I can really give the medication to the kid, or I don't really remember the dose. And then the elderly, it's like, oh, they really don't seem to be in that much pain. Again, we should be judgmental towards these patients. We should actually take them at their word, and that's what the research is showing, right? So those are just some of the barriers here. And then, is it pain or is it anxiety? All this patient is just worked up because, they're anxious. They see their foot's broken. That's not really, that really should never be considered there. If you do think it's anxiety, you can give a little bit of like a Versed or Ativan, but chances are they're still going to be in pain, and then you would want to treat for the pain anyways. But there are myths as well. And so, the old school way of thinking was, I'm going to treat what kills the patient first, and that pain is not life-threatening. Well, pain is one of those vital signs, as I said, that you need to treat. And I wholeheartedly believe that we need to be giving satisfaction surveys in EMS to the patients and say, how was your experience? And, I think that's going to guide some of our treatment in the future and what we do, and how these communities kind of reinvest in or support their fire department or their ambulance company. A big myth, and I've had this firsthand from a doctor when I was probably just about 8 years ago, is if I give pain medications, it's going to mask the physical exam of that patient from that doctor. And that's complete garbage. Because let me tell you what, if you have abdominal pain, I don't care if I push on your belly, I'm going to send you the CAT scan, right? So I know that you have flank pain. Well, I don't want to give flank pain. I don't want to give pain medicine because, it could be something else, or I've got this pain. I'm not sure what it is. Well, guess what? I'm going to do a costovertebral angle tenderness, and I'm going to send them again to CAT scan. So we need to make sure that that myth is out. Don't ever think that what you do is going to mask the assessment of that provider. 2 milligrams of morphine does not provide almost any pain relief, and it's definitely what's 2 milligrams of morphine is not going to provide the same for grandpa who's 78 years old. All right, not all people have the same amount of pain. They don't feel the same pain in the same way. And another big myth is opiates will lead to addiction. Well, there's actually no evidence that opiates will actually be able to, opiates given pre-hospitally will actually be, is there a mic, is there an open mic, Matt? Is there a video or something? But anyways, so that the myth is that pain medication, opiates, will not lead to addiction, all right? Now, if somebody is using, or somebody's a recovering addict, they may say, hey, please don't give me opiates, and that's one thing. We have alternatives for that. So we just got to overcome the myths and the barriers, because I think we're better than that. And again, if you remember Dan Batesy, for the EMS director of the state of Vermont, he said, we're the only profession that actually is governed by somebody who doesn't do our job, right? Nursing has nurses. The Board of Nursing governs the nurses. The American College of whatever physicians governs the physicians. But yet we're a field that is governed by a doctor, and maybe that doctor's opinion. Luckily at Trumbull, we have everything evidence-based, and Dr. Swift is a great medical director, because we can say, Doc, this is what the evidence says. Let's back it up by journals. And he says, why aren't we doing this? And so we do it. But, take pride in what you do, because you're on a same playing level as a nurse, And somebody asked me the other day, they said, what is the difference between an EMT and a paramedic? And I had to kind of explain to somebody, and I thought of the easiest way is an EMT is like a nurse, An advanced EMT is like a mid-level nurse practitioner, physician assistant, and a paramedic's like a doctor. And if you don't think that you're on that same kind of scale or that level, then I think you need to reevaluate why you're in EMS. And you know, I do think that we do a lot, and we're doing borderline practicing medicine and not just following a scope of practice. So physiological and psychological effects of pain can happen. We know that pain causes tachycardia. They can cause hypertension. But then when that happens, it increases myocardial oxygen consumption, right? We know that if somebody has a broken rib, that's going to inhibit the respiratory effort and then decrease their oxygenation, decrease their ventilation, decrease their SpO2. Their end tidal CO2 is going to go up. So pain has those physiological effects, but also it can lead to a PTSD disorder or some sort of psychological disorder where maybe they had this pain in the past and it's triggering them to go back to that moment, or maybe this pain that they currently have is going to precipitate a future event that's going to cause PTSD. So when we talk about classifying pain, just real quickly, you know, Joe talked about the spinal thalamic tract and the spinal cord injuries, but what happens is when you prick your finger, excuse me, or something happens to pain, the pain receptors are called nociceptors, and they're going to be, you know, triggered, and they're going to travel up the nerves to the spinal cord. And in the spinal cord, you're going to have neurotransmitters that are released, substance P, mu, and they're going to pass all those signals back to the brain. The thalamus is going to relay those signals to the somatosensory cortex in the brain, and then that's going to have sensory. The frontal cortex then is going to think about it, and the limbic system is going to store that in the body to say this is a painful experience. So let's go back to the kid getting their very first shot that they remember. That was probably a traumatizing event because somebody held their arm, they were upset. Here comes this thing they don't know. It caused pain, and now they tuck that into their brain, and they remember that needles hurt. So that's kind of how pain travels through the body, and that's how we store it in our brain into something that can make us uneasy. But we need to know that there are different types of pain. And so sometimes, you know, neuropathic pain could be electrical shock-like. Maybe we have some inflammation that's causing some numbness because the nerve can't communicate. Maybe that pain is shooting. It could be throbbing. It could be sharp. But we really need to figure out what the context is, and we need to figure out what happened to cause this pain, all right? And so we would go through a systematic approach if somebody had chest pain, right? We want to know, okay, what elicits this pain? What were you doing when this happened on a scale of 1 to 10 or 0 to 10, with 10 being the worst? Oh, it's like a 7 and it's a pressure like elephant sitting in my chest. We would dig down deep for chest pain, but I don't think we dig down deep for any other type of pain. And it should be done really the same way. When we classify pain, we kind of want to know a couple things. We want to know what's the underlying etiology or the source. We want to know where it's at, the anatomic location. We want to know the duration of the pain. And of course, we want to know how bad the pain hurts. And, you know, with this, then we're actually going to be able to figure out the best course of treatment for these patients. So nociceptive pain, all right, that's just pain directly from a tissue injury from a noxious stimuli. So those are your fractures. They can be lacerations and maybe a fresh burn. When you have inflammatory pain, that's caused by prostaglandins in the body that cause redness, inflammation, capillary permeability. And those are usually caused by tissue inflammation, as I said, but maybe that's appendicitis, cholecystitis. I've had the gallbladder issues, and I had to have mine out because whenever I ate, for example, Mexican, I would be in pain all night. And so like inflammatory pain, right? People who have inflammatory bowel disease, you know, and maybe when the burns are healing, they can have some of that too. Or maybe you have an ingrown toenail and you try to cut it out yourself, and guess what? Your toe looks like a big hammer, right? And so then you have some redness and it gets all infected, but it causes a lot of pain when you try to put your shoe on. Neuropathic pain, that's usually from nerves and some alteration in the sensory transmission. It can be peripheral, central in nature, right? Diabetic neuropathy, radiculopathy, like sciatica going down the leg. And then sometimes pain is psychogenic, but it's very rare. And so it's a psychiatric illness where they think they feel pain, but they don't. But that's not really what people call EMS. We're going to focus on some of the nociceptive pain here. Pain can have two types. It could be somatic, which is usually like skin, muscle, bone, and joints. All right. With these, they can actually be well localized. So I can pinpoint right exactly where this pain hurts, and it's like sharp, and it can be worse with movement, right? You got your typical lacerations, your fractures. But then when you have organ pain, you're going to have visceral pain. And normally, if you think about abdominal pain, the last time you try to ask somebody, well, tell me where your abdominal pain is, they kind of say, well, it's all over. And that's because it's visceral pain. It's very vague. Sometimes it's colicky, it can kind of wax and wane, and it aches, right? So, that could also be appendicitis. That can be cholecystitis, diverticulitis, right? And that can also be ureteral stones or maybe some other nature, right? So somatic versus visceral, and how that patient kind of describes to you, hey, this is sharp, this is dull, this is achy, will kind of get you to understand what type of pain this patient's experiencing. When we talk about the temporal or the length of time for this pain, we have 3 of them. We have acute, then chronic, then acute on chronic. So acute pain is any type of pain that lasts 3 months from a new stimulus, all right? So fractured bone, appendicitis, I smashed my finger in the door, that kind of thing. When you have chronic pain is those pains that last more than 3 months or beyond what we think they should last. And so back in 2014, I actually herniated 2 discs in my back. And so the acute pain phase was, I had sharp pain. I could pinpoint exactly what it was. And then that later became chronic and intolerable. But sometimes I have a flare-up depending on, the amount of work that I'm doing, or if I'm moving a certain patient or I slip. And then I have acute on chronic pain. And that means that I had a flare-up that's new of a chronic pain issue that I need to take care of. So I use my back pain, but also sickle cell is a big thing with that. And I think I've come in contact with maybe 2 sickle cell patients in my career, but I think it's worth noting that, an acute on chronic pain is just as important to treat than something that just happened like me cutting my arm. Then when we talk about pain, we also have to talk about the intensity, right? And so, there's a various different pain scales out there. And when I listen or I train students, they're so trained, say on a scale of 1 to 10, the 10 being the worst pain you've ever had, what would you rate it at? But they always forget 0 because 0 is none. And then some people they compare some event that they think is painful. Like if childbirth is, 10 out of 10, what would you rate this? Well, the chances are, females are getting epidurals or, they might be under some sort of sedation, so they don't know what childbirth was. So you can't really do that. So let them use their own numbers, let them use their own words when we go and we compare this. But pain, as Matt said with the overdose, pain can have it's multi-dimensional here, and it can be, it can be influenced by genetics or maybe culture. Maybe what we do in the Western world, with the opiates in America or trying to do that is not what they're going to do in the Caribbean or over in Africa. Psychosocial, socioeconomic. Maybe they can't afford to go to the doctor, so they're trying warm compresses, they're trying ace bandages. Maybe their religion doesn't allow them to have some sort of pain relief, or maybe they have certain techniques that they need to do first. So there's a whole different way of how pain affects us, and maybe it's looked down upon to go and get things done. But we got to be cognizant of all these factors when we talk about pain relief and when we offer them to patients. We're really good in the field at assessing, like I said, the chest pain, but maybe not so much of like the fractured ankle. I think it should be just as in-depth as, like I said, the chest pain, whether you're adult or child. And so what I would say is all patients who have pain are candidates for pain management, and you should try to make them comfortable, regardless of the amount of time it takes to get to the hospital. We're really good at memorizing the alphabet and doing mnemonics here in EMS, but just remember that one of our biggest allies is sample, right? So what's the signs and symptoms of somebody who fractured their leg? And then we want to know, is it deformed? Maybe they have some redness, maybe there's discoloration, maybe it's white, maybe there's no pulse. But then also we need to gather some information. We need to know that they have any allergies, because chances are we want to medicate these patients. We want to know what other type of medications they're on, because if they're on certain types of medications, it can inhibit the metabolism of the drug, and it can actually make it better or worse. We want to know their past medical history. Like me, let's use my example of back pain. Have this ever happened before? Yeah, it happened in 2014, then it's happened in 2020, then it happened in 2021. It has flare-ups every year. And then, last oral intake, a lot of these patients will get nauseous if you start to give them opiates. And so, we got to be cognizant of that. And then we also want to know the events leading up. The other acronym that we've all memorized since our National Registry skill sheets is OPQRST. And it's really good in figuring out when things happen. So we want to know when it started, what makes it better or worse. And then again, Is it sharp, dull, achy, crushing? Because that can kind of let us know, is it somatic or is it visceral pain? We want to know where it's at and does it radiate anywhere? And again, I'm going to go back to the chest pain, because chest pain, substernal or sternal, and then what's one of the things we ask? Does it go to your left arm, right? But the last ankle fracture you had, did you ask, or last fracture or pain anywhere, did you ask, where does that go? Maybe, maybe not. We want to know on a scale of 0 to 10 how bad it is. We want to know when it happened and is it intermittent and constant. We want to know the associated symptoms. I can't feel my toes. I can't move my toes. It feels numb. We want to know the pertinent negatives. Pulses were intact. Cool. Extremities was normal. So those are all important, and they should be documented on your PCR. And then again, if I have that chronic back pain, I know that I can try to use maybe ibuprofen, but then I know if I've had ibuprofen for 2 days, it's not working, and then it's getting worse, then I know I need to get into an urgent care or call my doctor, because I know that Flexeril muscle relaxer and steroids are going to help decrease the inflammation. So if I were to go, and it's happened, and I went to the urgent care for a flare-up last year, I said, look, this happens all the time. This happens like once a year, seasonal. This is what they give me. The Flexeril works well and steroids work well. And I had a nurse practitioner, and she said, well, if that works, that's what I'm giving you. So we need to have that same concept, or that same way of thinking, because if the patient knows that 1 milligram of Dilaudid works, it's not that they want Dilaudid, it's that they know Dilaudid works. I have a good friend, and she has Crohn's. And so I remember she had abdominal pain. And so she had biopsies and things like that. And they couldn't really say that she had the Crohn's on her medical, but they knew that she had the symptoms of it. So they just said, you have Crohn's, atypical Crohn's. Well, I was visiting her, and one day she was in an acute flare-up. And so what we did is took her to the hospital, and went to the hospital, and then she was assessed, and then the mid-level practitioner came in, the nurse practitioner says, what's going on? I've got Crohn's. It hurts right here at the terminal ileum, which is the lower right quadrant. I need pain meds. And, I'm not a drug seeker, but 1 milligram of Dilaudid works. And they said, okay. And they came back with 1 milligram of Dilaudid. They watched her, the pain relieved. They were able to see the change in vital signs, and off she went. And it worked well. So again, patients are usually their best historians, and we need to listen to them more. All right. And then, of course, we need to know allergies, but we need to know what's a true allergy and something that maybe is not a true allergy. So an allergy for hives is different than an allergy, like an adverse reaction, than like nausea, vomiting, makes me dizzy, made me so sick. Oh, I'm allergic to that. So really, really need to ask about that. So usually when we talk about pain, I told you we ask adults, is it between 0 to 10? But it doesn't really go into anything else other than intensity. And so that's where OPQRST comes into play at. But all the pain scales have been developed for hospital use. And so they're rated by the Joint Commission and the satisfaction surveys. And so if the last time maybe you did a transfer, you went to the ER and you saw your doctor is Dr. Larry, your nurse is Nurse Ratchet, and then today our goal is to make you pain-free and then mark your pain on the whiteboard. That's because, a lot of hospital systems are graded by how comfortable the patient is and how well they thought that you took care of them. So, and again, I think that we can kind of incorporate that a little bit into EMS and say, hey, how was your experience with EMS? Because I think that'll weed out a lot of the problems that we have. But how you assess a pain in adult is not the same of how you assess pain in pediatrics and maybe the elderly. But again, nothing has been proven to 100% be valid in pre-hospital. So we have to kind of go with what they have in the in-hospital settings. In 2013, the National Association of EMS Physicians, they made recommendations. And so we're going to go over those recommendations. But sometimes it's observational and behavioral versus self-report. So we're going to talk about that. So again, it's based off of trauma, these pain scales. And so what they did is they wanted to look at trauma patients. So they had an age group of less than 4 years old, 4 to 12 years old, and then greater than 12 years old. So based on these age criteria, they actually came up with what they thought was the best. And when I say they, it was about National Pre-Hospital Evidence Guidelines. And this was actually published in the Pre-Hospital Emergency Care Journal back in 2014. So when you're less than 4 years old, you should actually do the FLAC score. So FLAC, F-L-A-C-C, assesses the face, legs, activity, cry, and consolability. So it's similar, like it kind of has a similar look to what an APGAR score looks like. But your zeros would be normal, your 1 would kind of be a little bit of pain, and your 2s would be extreme pain. And in each category goes from calm or normal to worst pain. You could sit there and read it, but you know, if we want to be evidence-based, then we need to make sure we're using this on all of our pediatric pain here. So let's just take a child, and one of the first things we know about a child, if they're in pain, what do? They cry. So a child who's really not in any pain would not cry. We're number 4 down here. A child who moans a little bit or cries a little bit, like for example, if I touch their leg and their leg's broken, that would be a scale of 1. And then if they have, you know, they're just screaming and inconsolable, that would be a 2. So you would do that for every single thing, and you report the total score for that. When we talk about that, you know, we're observing this patient, and so that's going to be good for the age under 4. So of course we're going to look for facial grimace, we're going to look for tone, if they're guarding, you know, if they're irritable, you know, and then maybe chronically, are they having trouble feeding, or maybe they're not sleeping well. But you know, we just kind of want to look at the face, and I think the face tells everything. And for children 4 to 12 years old, we want to use the Wong-Baker faces. That's what the research is saying. So you would hold this up to a patient, and you know, somebody who maybe couldn't say, you know, it's a 4 out of 10, you would give them this face, these faces here, and you have them, hey, which one is this? Which one does it hurt? And so if they select yellow, then you're going to know that should equate to about a pain scale of 4. And if somebody says, that kind of hurts a little more, that's a 4. So this is what we should be using, and it works well in children. Now, for adults or anybody greater than 4 years old, we want to use a number score. So again, it should be, your question should say, from 0 to 10, could you rate your pain? And then we know internally that 1 to 3 is mild, 4 to 6 is moderate, and then 7 to 10 is severe. So if I have somebody say, hey, tell me what your pain is, for them to be a 5, for example, or let's go over here. Let's go with 3. For somebody to be a 3, they would have to say to me, it's very distressing. Well, if you tell me it's very distressing, I'm going to think you're more than a 3. So this is if they would, on the right-hand side is a chart if they would say it and what their words or their adjectives are, should be. And then on the left is a number. And I think a number is a lot easier rather to say than, okay, I think this pain is 10, which is unimaginable and unspeakable. I've never said this pain is unspeakable. So we should be using the number chart. I think it's easy there. And then one of the things that I was guilty of early in my career is I said, you know, when somebody would speak up for the patient, say his pain's 10, I would say, no. I need to talk to the patient. And that's true to a certain extent, but we need to actually listen to the surrogates or that guardian or that mother of those patients or father. We need to figure out, you know, hey, this patient, you know, is really not acting right. I know him. This is not him. And we get that a lot. But sometimes I think we're quick to ignore them and try to talk to the patient directly. So, you know, take everything in the big picture and listen to the surrogates as well as the patients and come up to your own conclusion. So, again, we kind of said that there's no real great pain scale and documentation for EMS, but we kind of got to go with what we have. All right. And so, again, what is a 5 for me is not a 5 for maybe Joe. And I can tell you that when I was in 8th grade, I was hit in the head with a shot put. And so I had glasses on, and so I was in track and field. And so if you know anything about shot put, you can either spin 180 degrees, you can spin 360 degrees, you can throw the shot put out. Well, this kid decided to do it 360 degrees and did like a 720 and threw it the wrong way. And it hit me. Well, I wasn't looking because I'm not in the right area. I'm not supposed to be in the danger area. So this shot put came, and I had glasses at the time, and it came and it struck me right here in my head, and I actually have a scar here. So the lens from the glasses split my skin open, and so what I recall blood gushing. I recall my teammates picking up a dirty towel because it was muddy outside that we wiped the shot put off, putting it on my head, and then my buddy ran and got help. I didn't feel pain. I didn't feel pain. But then when I went into the ER and the lidocaine wore off and I was getting the last 2 stitches, I felt that worse with the needle going through and the thread being pulled versus the impact and the pain from the shot put. So, you know, just because the injury doesn't match what you're feeling doesn't mean that we should be guiding our pain medicine based on what the injury is or what, you know, and we should be based it on how the patient feels. All right. And again, for chronic pain, I already said I use myself as an example. What works best? What's my baseline pain? Like, I don't have baseline pain, but I know it comes up. And so you just need to ask, you know, compared to normal, where are we today? When we talk about pain reduction, this is what our goal is. This is what the goal in the hospital is. We want to kind of, see how far from my pain was 7 out of 10, how far it came down. We want to reassess the pain about every 5 minutes. So when we do that, we're looking for a minimally clinically significant difference, all right? Minimal clinically significant difference. And so research is saying that if I can drop the pain by 5 points on that 0 to 10 score, then I've achieved my minimal clinically significant difference. So I'm looking for a drop of about 1.5 points. And if I can get a drop of 1.5 points, then I know my pain treatment is working. So that's good, right? That's what we want to try to do. But the other challenge is how does NESEMSO, how does NEMSIS, how does the Emergency College of Emergency Physicians or EMS physicians, how do they get this data? Well, I was guilty of it early on, like I'm just going to put everything in the narrative. And then as PCRs developed to electronic, we were able to kind of track a little bit more. And so what happened is instead of putting things in a narrative, pain was 10 out of 10, decreased to 7 out of 10, no incidents, pain, EMS clear, whatever. Now with our vital signs, right on the same line as heart rate, SpO2, respiratory rate, we have a pain rating. And we should be using that drop down or that pain rating in the vital sign because that's what's going to track the future outcomes, and that's what's going to track minimal clinically significant difference in pain. That's going to show that you did something for your patient. That could actually lead further down the road to reimbursement. And then that's where these physicians or the data collection, they get the resources and say, hey, Larry in Trumbull County, in the Trumbull County health system, uses fentanyl. Fentanyl was average to give, pain relief about 3 points difference. And that's how we're going to guide these treatment modalities. So again, if you have this documentation system or ePCR electronic that has a pain drop-down menu, please go ahead and use that because that's how we're going to guide future treatment. So again, we know how to assess a patient, but I think we get lax in certain types of patients. So not only are we going to do a physical exam, either a rapid trauma or focused medical, we need to document the vital signs, and pain is a vital sign, right? So we don't want to kind of gauge our treatment solely on the vital signs, but we should make that part of our whole assessment. And so with this, we need to, look at the skin as well as the injury. So this is a real life patient that just happened last week. I won't say where it's from or who it was, but you can see that this was like a deformed ankle, and right here is a clear linear demarcation of this ankle. So EMS actually puts an X there for the pulse, so they checked what they needed to check for. But now you have to ask yourself, and I was asked this by the paramedic, why did the doctor in line of triage reset this ankle? Why did they manipulate this ankle? And my immediate answer was, right here. You have 2 different colors. You have pink and then you have white. Even though you have a pulse at this circle here, you have 3 pulses in your foot. You have a tibial dorsalis and then the anterior tibialis and then another one. There is some sort of blood flow that is not getting, which is why this area here is pale. And the other thing is, this patient, because even though they had pulses, the providers probably should have realized that there was 2 different colors of this patient, and they probably should have ran a red and went to the trauma center and said, I have discoloration there, right? So there could be other factors, but my reasoning is that the ER physician immediately reset that in line while the patient was on the cot in triage, because you have that demarcation line, and so that would be reason for concern. You can see that the skin is 2 different colors, and I would go to imagine that maybe they were 2 different temperatures, with that too. So again, look for all your signs, right? It's not just a matter of trying to figure out, what's your pain? And I've got 1 pulse, but we need to check for all the different anatomical pulses. And then with pain, we need to reassess, just like we would when we give nitro, right? Or we give anything, we reassess the vital signs. And so pain, I think, can be classified as a critical vital sign, because when you have a stable patient, what do? You reassess blood pressure every 10 to 15 minutes, right? But with pain, we got to move that up, and we got to move that up to about the 5-minute interval. We want to know what their pain is every 5 minutes, especially if we're trying to decrease that pain. And again, we said minimally, we want to decrease that by about 1.5. And if that patient still has pain, or we haven't hit that 1.5 point decrease, maybe consider giving some more pain medication, right? But then you got to kind of watch, you guys, well, I don't want to sedate them too much. So wouldn't it be cool if we had a tool to assess for that? Well, we do, right? Because Kristen and I talked about this on Tuesday. We talked about the Richmond Agitation Sedation Scale. And so we know that if somebody's agitated, somebody's kind of restless, we kind of give them a positive value over here. But, you know, we kind of want them to be calm. So not only can this work for psych, this can also work for pain too, as far as like, you know, I did not redose the patient with pain medicine because the patient was a -1 on the RASS score and they're kind of drowsy. I get that, right? Because what did we say on Tuesday was our optimum level we wanted to be at? We wanted to be at 0, which is alert and calm. If your patient is becoming more sedated, we're going to go in a negative fashion here. And of course, if a patient's drowsy, I don't see any reason why you would give pain medication because they're sleeping it off. So let it be that. All right. So one thing that we're requiring from our providers here in Trumbull County is, in addition to the pain scale, we want you to document a RASS scale as well. I'm going to do that every 5 minutes. So pain is inevitable. If I get run over by a truck, I'm definitely going to have pain, but I don't have to suffer. And so that's one of the things I think is important. So, you know, we have pharmacological and non-pharmacological options. And, you know, I've transported so many kids, you know, on a little bit longer distance to the pediatric center that we have here, Akron Children's. And I can't tell you the amount of times that I said, turn up the radio and let's just jam out in the back of the ambulance, because kids think that you're having fun at that point. They're not as scared, and it kind of relaxes them. Also, I put the mother, the guardian, whatever in the back with them because they're the most likely to console those patients. So these is a great way. You know, obviously for any other patient, we have the traction splints, you know, we're going to try to do that with cold packs and hot packs as necessary in the position of comfort. Because again, why am I going to put myself in a certain position that's going to cause more pain? I know that when I have back pain, that I need to kind of like lean over to the side. I don't want to put pressure on my sacroiliac joints, okay? If it's a kid, you know, maybe try a pacifier. But one of the biggest things you can do is have empathy. And they usually talk about a doctor's healing touch. And I think that can kind of move from, you know, medicine to pre-hospital, because the doctor's healing touch was just kind of like, as this physician's doing here, is just kind of touching the patient's arm and reassuring them that you're listening, right? And then that's going to help to kind of mitigate their pain and let them know that you kind of have some, you know, trust in you. One of the things that I do, and I've done that since I went to medical school, is I said, hi, my name's Larry, and this is Matt. How can I help? Versus, what did you call? Because why did you call and not introducing who these two strangers are in your house can be a little standoffish, but that's not going to build a very good rapport either. So you want to get the patient's trust. You want to trust them just as much as they want to trust you. You want to show them that you care. And I think a lot of times, especially, you know, what Matt said with the opiate overdose endemic, is that we get desensitized to this. And we got to remember, you know, you're not a career fireman without doing EMS, really, right? You know, EMS is the wave of the future. And unless you have a pure fire department that doesn't run EMS, then, you know, I think we can all get back on the empathy track and just kind of be a little more human. Also, you know, this is more so for in settings, but the RICE mnemonic also works. Again, memorizing the alphabet, but, you know, try not to move it. Let's ice it. Let's kind of put compression on it, maybe elevate it, splint it, and then position it where we need to go. The funny thing is, you know, traction splints are one of those things that are required on the ambulance, but the studies show that it really doesn't even get used, right? So if I have a femur fracture and I've got a femur fracture, this is my femur, but now all of a sudden it's like this and it's not protruding through the skin, what's happening? These are my bones and they're jagged into the quadricep femoris. But now what I want to do is I want to pull on these, right? And I kind of want to realign them a little bit so that they're not jagged into the muscle. And so by doing that, I can cause pain relief very easily. Now, if it's piercing through the skin, I don't want to do anything with that. I just want to kind of document it, splint it, and move on. But if it's like this and it's not protruding through the skin, then I can realign that, and that does wonders for the patient. For kids and even a little bit for adults, we can try some distraction techniques for non-pharmacological options. And so, it works really good on children. And, maybe you go to the dollar store, you buy some, non-hazardous toys or some noisemakers, and you put them in a bin and you stuff them next to the stuffed animals that you have under the CPR seat, right? Maybe you get them some bubbles and they can blow some bubbles to kind of have some fun in the back of the ambulance. You can have them kind of tell you a story, or you can, talk to them. But one of the things I think is big is get down on their level so you don't look so giant and scary. And if you need to, bring some parents into the back or have them kind of guide through or let them know, tell them what's going on. And so one of the examples of a toolbox for kids is the University of Florida Jacksonville campus and their medical center. They put this together, and they have a toy stethoscope, right? They have a little Superman. They have some, kind of fun little keychains that we can just give to them, and they have a pacifier or maybe a sucrose pacifier with some sugar on it. And so I think if you have one of these kits, dealing with kids would be a little bit better, and you can kind of distract them, and maybe they won't be as, inconsolable. But that's just something I didn't think of until I actually reached out to them and they gave me this idea. So again, conversation, distraction on ages, whatever you need to talk about. One of the things that kind of gets me ramped up, I think, and anybody who's had me as a paramedic preceptor, is you talk to your patient. You don't sit in the airway chair and just work on your PCR. You should be on the bench seat. You should be, talking to your patient and making them feel like you're there for them. So, one of the things that's interesting is pain can be reduced by about 25% just by distracting them or talking to them. And that's good for all ages too. So, just be that compassionate, empathetic patient and caregiver, and it'll go maybe a little bit better for you. So we're going to get into some drugs here. And one of the things I'm going to import that I did is I used the NASEMSO PICO questions in their guidelines and how they actually develop what drugs they should recommend for all EMS systems out there. But before we do that, again, we want to consider all patients with acute pain as candidates for pain management, all right? And if they have mild to moderate pain, we can try to give some NSAIDs. But if it's moderate to severe, we want to go opiates and ketamine. So with NSAIDs, they're really good for some inflammation and for some musculoskeletal sprains. NSAIDs work by actually inhibiting COX-1 and COX-2. That's COX-1 and COX-2. And those are responsible for prostaglandin inflammation and tissue platelet aggregation, and the redness and the capillary permeability. So if we block those, we can reduce the inflammation. We can reduce the capillary permeability. We can reduce the redness and the tenderness and the hotness to that area. But one of the things is, most NSAIDs, with the exception of Toradol, we have to give by mouth. And sometimes we don't want anybody taking things by mouth, right? If they have an allergy to NSAIDs or maybe some peptic ulcer disease or GI bleeding, we really don't want to give it. And we definitely don't want to give it to children less than 6 months of age, because they could have some defects, or maybe their patent ductus arteriosus haven't officially closed yet, and we don't want to kind of affect that. But NSAIDs work, and you're going to see NASEMSO says they favor NSAIDs over opiates in some cases. So one of the main things we give is Toradol. We know it's good for mild to moderate pain. For an adult, we can give 30 milligrams IV. We can give 60 milligrams IM, and that's if they're less than 65 years old. If they are older, we want to cut that down. We want to give half of that dose usually. And then, it's good. It's really good for kidney stones. We kind of want to watch and give it to anything else because of severe bleeding. But Toradol is good. It's an option to give to patients. Some systems are moving to putting some Advil on the truck, but this is usually done before they even call EMS. So we know that we're going to give, for Motrin or Advil, we're going to give 400, 800 milligrams every 8 hours. But it is in use, and that is something that people advocate for in EMS. So Advil and Toradol are pretty good for the NSAIDs. Tylenol is not an NSAID. Tylenol actually works. I don't have it listed here, but the medical abbreviation for Tylenol is actually APAP, and that inhibits. It's going to be COX-3 And so what COX-3 is it sends pain pathways into the brain, the spinal cord, and also in the heart. And so if we use Tylenol, we're actually blocking COX-3 so that we kind of inhibit the transmission to the brain in the spinal cord for some pain. Now, some pain is so bearable, or I'm sorry, some pain is so extreme that we can't actually use just Tylenol. But if you remember from our ACS lecture with Dr. Bogdan, we said that we're switching to Tylenol for STEMIs and for chest pain. That's why Tylenol is on COX-3, and COX-3 receptor is actually in the heart, and that's how we can decrease the pain from an MI, the same efficiency or efficacy as fentanyl. All right. So for moderate severe pain, we want to talk about opiates. All right. Opiates, we use it. They're fentanyl, Dilaudid, morphine back in the day. And, you know, we know that we have an antidote for that. It's Narcan. But if the patient has a hypersensitivity or known allergy to that, then we probably won't want to use it, right? We don't want to really use it in anybody who has respiratory distress or low pulse oxes. But they do work very well in the setting of, you know, acute traumatic pain. One of the things that I hear is, oh, Dilaudid is so much better than fentanyl. Well, that's garbage. And the reason it's garbage is because 1 milligram of Dilaudid is equal to 70 mics of fentanyl, and 1 milligram of Dilaudid is equal to 7 milligrams of morphine. They're all relative in their dosage, which is why one is just as equal to the other. Now, I will tell you that hydromorphone, which is Dilaudid, and fentanyl are hemodynamically stable, whereas morphine is not. It's more of a natural opiate, so it has histamine effect, has more respiratory depression and things like that. But to come out and say Dilaudid is better than fentanyl, I'd like to know the research that you've actually looked that up, because that's not true. So think about the amount of fentanyl that you gave. Normally it's 100, right? 50 to 100. And then you can't compare that to hydromorphone or Dilaudid itself, because you already gave more fentanyl, for example. So 100 mics of fentanyl does not equal 1 milligram of Dilaudid. It's actually 70 mics is 1 milligram. They all are relative. They both work. All three of these work on the mu receptors in the brain. So one is not necessarily better at achieving pain relief than the other. It's just how it's packaged. You think you're using more, but again, a microgram is less than a milligram. So which one is more potent, right? The fentanyl. So they all work the same. So I kind of laugh at protocol systems that have fentanyl and Dilaudid in the same thing, because they're essentially the same. So morphine. Morphine is an old school drug. It's really not used that much anymore in EMS, more so in the hospital setting. But for an adult, we used to give 4 to 10 milligrams of morphine. Usually you couldn't give any more than 4 milligrams of morphine without calling in for orders. And doctors like, oh, no, you can't do that. So the onset for morphine is about 5 to 15 minutes. It can last up to about 4 hours. And again, we weren't really allowed to give that much. It caused a lot of respiratory depression, hypotension, bradycardia, had CNS depression. So they kind of took it out. And most places, I mean, they use it as a backup, but fentanyl is considered the superior drug for opiates. And morphine's a pregnancy category C, and what that means that, you know, there might be some risk to the fetus, but the benefits outweigh the risk. When we talk about fentanyl, fentanyl is endorsed by the National Association of EMS Physicians as the drug of choice for opiates. Normally, the dose is 1 mic per kilo. And you should give all drug pushes over 3 to 5 minutes. If you give it intranasally or intramuscularly, we want you to increase that a little bit. But it's quick at onset, 1 to 2 minutes. It lasts for about 30 minutes, and the max dose, usually the consensus is saying about 300 mics. Dilaudid, IV and intramuscularly, this would be the inferior drug because you can't give it intranasally. Usually it's 0.5 to 1 is the initial dose. You know, same onset time of 3 to 5 minutes, lasts about 2 to 4 hours. So yeah, it may last longer for that patient, but again, when you get to the ER, they might not dose that patient up with any more meds because they had Dilaudid. And your max dose is 2. Ketamine. Ketamine is going to be what's indicated for bone pain, and usually the consensus dose of this is 0.1 to 0.3 milligrams per kilogram. Nisemso, the guidelines from the National Association of State EMS officials say just go ahead and give 25 milligrams of ketamine as regular standing pain relief. That's a lot. Usually we're starting out at 5 to 7 milligrams, and that usually works very well. The onset is very quick because it's lipid soluble. It crosses the blood-brain barrier very quickly. All the opiates are, including, and then ketamine as well. That's why they are weight dependent. Ketamine and fentanyl especially. So that's why if a patient weighs 300 pounds, you should dose them higher than a patient who weighs 100 pounds because they have more fat. If they have more fat, that drug is going to sit in the fat and it's going to work better. So if you give somebody who's 500 pounds the same amount you would give somebody who's 100 pounds, they're not going to have pain relief because it's not going to be distributed in the fat as much as it needs to be. So really, if it says milligram or mic per kilogram, we want to make sure we adhere to that. So we all know that the opiate side effects can have constipation and bowel ileus and dizziness, respiratory depression, some nausea, vomiting. But we should be dosing these patients pre-medically with pre-pain management. We should give some Zofran, some ondansetron, that's a serotonin 5-HT3 inhibitor. So what that's going to do is it's going to suppress the area postrema, I think, and the chemoreceptors in the brain, and that's going to prevent them from being nauseous. And it's relatively safe. In the state of Ohio, an advanced EMT can give Zofran ODT. That's what their medical guidelines say, and a paramedic can only give it intravenously. And that's because of the state medical direction and the rare risk that you would cause prolonged QT syndrome. So we can't change anything with that. But again, we want to make sure that we're being cognizant of what's going on. We know if we give too much, we could reverse it, but that's not our goal, is to give too much. We want to give weight and appropriate dosages to those patients and observe the airway. And especially, now, we have capnography. We didn't monitor these patients with capnography. National Association of ENF physicians say that, nitrous oxide works well, but there's a huge cost to that, maintaining that, having more room on the ambulance for that. And then the risk of leaking and everybody having like a cool party in the back of the ambulance. But they say it works well. I've never used it, but it is one of the pain options as well. And I'll let you here to read it because I know we're over time. So what I think is big here is this is what NASEMSO, the National Association of State EMS Officials, say, and these are their slides. So when you see PICO, PICO is a format of a question. So P stands for problem, I stands for intervention, C stands for comparison to the control, and then O stands for outcome, all right, or recommendation. So that's a PICO question. So number one question they posed, and this was just released last year in 2021, should intranasal fentanyl versus intravenous opiate be used for kids with severe pain? And it says they recommend using intranasal fentanyl over an IV or IM for pain relief. One of the reasons is conditioning of the pediatric patient. They don't want them to be afraid of needles. Also, if you have a kid and you're coming at them with a needle, chances are they're not going to be cooperative. And then also, we can give it naturally, and it works pretty quickly too. So state EMS officials recommend intranasal fentanyl over top of IV opiates. It's pretty easy to use, and that's why. PICO question number 2 was, should IV Tylenol be used over IV opiates in the pre-hospital setting for severe pain? And they suggest IV Tylenol if it's available and if it's cheap. There was a couple of years ago that IV Tylenol was $1,000 a gram in a bag, and that you can go out and buy Tylenol over the counter for what, $3? So people didn't put it into the protocol because we were going to do this 3 or 4 years ago. But now they're generic form, and it's a lot cheaper. So the reason is they say Tylenol, IV Tylenol is better is because it has equivalent pain control. I told you about COX-3 inhibitor, and it's well tolerated. All right. The disadvantage is that it has to be a bolus or a push, and it can be very expensive. I don't know anybody routinely using it right around here, but I know that we've implemented it in our pain protocols coming out, and we'll see the drug box changes soon. Tylenol causes less dizziness, nausea, and so that's another reason why. PICO question number 3, what's the problem intervention comparison to control and the outcome? Should IV NSAIDs versus IV opiates, so your Toradol versus your fentanyl, be used for severe pain in the pre-hospital setting? And they say either one of them is good for the management of pain in the pre-hospital setting. They have insufficient evidence to say that they can recommend any difference because the pain at 15 minutes, the pain scale is exactly the same. All right. The problem is Toradol is a little bit more expensive than opiates, right? So again, whatever the medical director has or what they want, they're equivalent in their minds that you can use either one. But if you have an opiate allergy, then use the NSAIDs if possible. Don't give it for active bleeding. But again, you're going to see these are going to overlap. All right, IV Tylenol versus NSAIDs. NSAIDs because of, I think, the cost. And also because it has a little bit better, but NSAIDs are going to win here versus the two. No difference in pain at the 30 or 60-minute level. Pain relief, they're very comparable in adverse effects, but because of the cost, it favors the NSAIDs. All right, IV ketamine versus NSAIDs, either or. And the reason they're saying either or is that pain relief at 30 minutes after Toradol compared to ketamine is significant, but within the 15 to 60 minute time, there's almost no relief there. Side effects, they say, slightly higher with ketamine, but they're equivalent as far as the National Association of EMS officials are concerned. Should ketamine IV versus opiates be used? They're going that they say that they're equal. No clinically significant difference at pain at 15, 30, or 60 minutes to total analgesic effect. So they're essentially equivalents there. We do know that ketamine works better on orthopedic pain, and fentanyl works a little better on visceral pain or the organ pain. All right. These will be put up there. For the sake of time, I'm just moving through to the next question here. All right. Morphine or fentanyl is equivalent. All right. Natural, like opiates, like morphine, have more analgesia. Have more respiratory depression and physical dependence and constipation than maybe the fentanyl does. All right. So here's a big one: should combination of weight-based IV opiate and ketamine, weight-based, versus the IV opiate alone, be used to treat severe pain? And what they're saying is no. They're not. They're saying that you should not use an opiate first and then a weight-based IV ketamine. And the reason for this, not only is there isn't really a lot of evidence, but they actually claim that EMS professionals cannot do math in the back of an ambulance and figure out weight-based. So for me, I know that fentanyl is 1 to 3 mics per kilo, and I also know that ketamine is 0.1 to 0.3 milligrams per kilogram. But they're saying that average people don't know that, and I find that offensive. But I think we should be able to do this. But there's not enough evidence to kind of say that. There's a huge risk that they saw. So now they switched the question. They said, should combination of IV opiate plus ketamine versus ketamine alone be used? And they say there's no recommendation. Well, didn't we just say that they can't recommend IV opiates first, then ketamine is a no? But now they're saying IV ketamine plus then IV opiates versus ketamine alone is no recommendation. So here's a little bit of physiology real quick, is that if you give IV ketamine, it's going to not only take care of some of the pain and the glutamate receptors ascending into the brain, but it makes the mu receptors for opiates hypersensitive. So we can give a little bit of opiate with that, and we can have maximal pain relief by combining ketamine first with maybe half the dose of maybe fentanyl that we're normally giving. But there's not enough studies that to say that. But at Trumbull, we're saying go ahead and do that. So give ketamine and then be cautious, but you can go ahead and give some opiates, maybe at half. So give the ketamine full dose, then give opiates like the fentanyl, maybe half the initial dose that you would give. And that's going to have great pain relief. But nationally, they're saying you need some more. And then nitrous oxide versus IV opiates, no recommendation between the two. They're saying that they're equivalent. So I know that we're almost 30 minutes over. So, but I just want to kind of show you this slide. And so the same thing, does it achieve, does pain relief, is it achieved with opiates and ketamine together? And I want you to kind of focus on this column here, is that opiate plus ketamine versus just opiates alone. This is done by a pharmacy group. They said that the combination between the two could be more effective. But again, there's the data, the yellow boxes are insufficient to support that, but there's a strong suspicion in some of the small research studies they did that support that. All right. So, just kind of going through this stuff, just, when you have a pediatric patient, we talked about distraction techniques, speak calm, get on their level. When we talk about elderly, I just wanted to share this statistic with you. I think it's important. Only 28% of elderly patients greater than 60 years old with a hip fracture receive pain medicine by EMS. And those who did actually had a 5-point drop in their numeric from 7 to about 2.8, right? So we're less than 1/3 of all elderly patients are getting pain meds, and I think we could do better. Again, they don't have a lot of fat. And what do we say about opiates? It's fat or lipid soluble, right? So we want to make sure we kind of decrease the amount that we give. But again, use it based off weight. If you assume somebody is 100 pounds, go ahead and give it based off of that. Just be careful. And again, Joe's got a really nice lecture on elderly populations. I might ask him to speak in February about the differences in metabolism and organs and with the elderly. But elderly has decreased hepatic, metabolic, and renal function. So we just kind of want to be careful. That's why when we talked about Toradol, we said decrease the amount of Toradol you're giving, because Toradol and NSAIDs are renally excreted. That's why they're very good for kidney stones, because they actually go and accumulate in the kidney. So just be cognizant of that for the elderly. And pregnant females, they need pain relief too. So you heard us say that fentanyl and Dilaudid were pregnancy category C. And so they show a little bit of an adverse effect, all right, but there's not really a well-controlled study. But the thing is, if you need to give it, then you give it, because the benefit outweighs the risk. Anything with pregnancy category D or X, we really don't want to give. And when we talked about ketamine, they just didn't do any studies with that, so that's not classified at all. All right. We kind of mentioned somebody who's 500 pounds should get 500 pounds worth of medicine, except for what that hard stop point is, which is like 300 mics in the fentanyl. So use it based on the weight, and just don't say, I'm only going to give 100 mics. So, again, chronic pain, what is your baseline? What do we need to do? Where can we go from here? And then with somebody with chronic pain, where would you usually go seek treatment? Oh, if it's a 5. Okay, so if you would normally seek treatment at a 5, what is it now? It's a 7, so we can kind of gauge it from there. All right, abdominal pain, myth was that I can't give pain meds because it's going to mask the abdominal pain. That's garbage. Anybody who's knows that you're going to go to CT, you're going to get a CT, and you're going to figure out what's going on with the patients. They actually did a study, which I thought is also interesting. They in 2011, they released a study. They had 699, almost 700 patients were given either 5 to 15 milligrams of morphine or the equivalent amounts of normal saline. They masked these patients. They went into the ERs, and the study found that there's no significant difference between the two groups, either getting morphine or saline, in terms of accuracy of the diagnosis of that physician, which I thought was kind of interesting. But they also, obviously, they found that patients who had morphine was actually able to get pain relief. So this here kind of debunked that myth. Fractures, we know that ketamine is good for orthopedic. But again, fractures, only 1.5% of patients received analgesia with fractures. All right. Burns, opiates work very good. Matt went over the Parkland burn formula for you there a couple of nights ago, but please don't hesitate to give pain medication to these patients. And then sickle cell crisis. So sickle cell crisis, for those of you who don't know it, that's supposed to be a normal blood cell. And then with sickle cell, I have kind of like this weird cell. And so what happens is I try to go through a vessel. What's going to happen is these can turn and turn. And so what's going to happen is I'm going to have these sickle cells kind of block that. And so these patients, they need pain relief, and opiates work well for them. And they're going to need fluid because they need to push this stuff through the vein. And then they also need some oxygen because the blood, it doesn't hold the amount of oxygen in the blood cell that it would normally need to. So IV, O2, and pain relief. The whole old school term IV O2 monitor for sickle cell crisis. All right, so what we need to do, standardize pain management across the area, make sure our local hospitals know what's going on with what to expect. I remember when we launched ketamine, St. E's nurses were like, oh, no, I'm not doing anything with that. It's because in their ER setting, their protocols do not allow them to do that. Same thing back in children's. They were like, oh, we can't waste ketamine. That's beyond us. We can't do that. And again, that's where I say you need to consider yourself on the same level, just a different field as doctors, because we're doing things that nurses are not allowed to do because we don't have the time to wait. We have these, we got to do what we got to do to get them to the hospital. You know, somebody said, trauma coordinator, I think, told me that ketamine and fentanyl was conscious sedation and that they're not allowed to do it as a nurse. Well, guess what? We put people to sleep. We do what anesthesiologists do with RSI. So again, give yourself a little bit of credit for what you do because you do make a difference and you should hold yourself to a higher caliber, I think. So what do we need to do? Monitor their heart rate, their pulse ox, and capnography is big, all right? Know their allergies, document those pain assessments on that number scale, document the vital signs, and make sure you're doing that every 5 minutes. What medication did they get? When did you give it? And if you redosed it, that's all big, right? You need to relay that to the receiving team. We can do better as a group by, you know, doing QA internally and also with the hospital system that you're going to. And again, require certain things for those EMS people or for your agencies there in order to see how well you're doing. One of the things I wanted to introduce to you, if you haven't known this, is like the MIST format. When I listen to patients or the EMS give patient reports on the phone or even to nurses, you know, they're not really, I don't want to say they're not professional, but they can kind of be nonchalant about it. And so you're kind of going all over the place when you're looking to kind of give the information. So one of the things we want to do is we kind of want to do this MIST format, or sometimes they call it DMIST because D means demographics, which is right there. So, you know, Larry is a 35-year-old male. That's my demographic. We're going to talk about a medical complaint who has complained of back pain for 3 days. He has a history of herniated disc, and he had acute on chronic flare-up, all right, with his pain being enough that he had to call EMS. You know, no midline deformity, you know, things appear to be okay, no shortening rotation of the leg. So my injuries or the illness, I want to go into my signs and symptoms and say my heart rate was 80, my blood pressure was 130/70, SpO2 98%, respiratory 14. And title is big if I give him pain meds, but also my pain scale, right? Pain right now is 5 out of 10. All right, and then what treatment we gave him? We gave him some 70 mics of fentanyl, right? So who you have, DMIST, right? Demographics, the mechanism of injury, the medical complaints, the injury or illness, the signs and symptoms, and the treatment. And if you do this all the time, you're going to not only like be the professional, you're going to sound professional as well, instead of trying to kind of beat all around the bush and figure out what you want to say. So this is a very good thing. And I just want to remind you that hospital systems are starting to have a 30-second timeout as Stewart, which is Sharon and Trumbull, for those who are locally, and I think even some of the bigger hospital systems, they're supposed to give you 30 seconds of uninterrupted time, whether it's a trauma team, a cardiac arrest, or even a paramedic or EMS to nurse report, where you say what you want to say. And how do you say what you want to say? You use this format, MIST or DMIST. All right. Just want to share our protocol out there. Again, we have calming techniques, actually, those distraction techniques in our protocol. We have non-narcotic options here at Trumbull. So do I want to give acetaminophen by mouth, or do I want to give it by IV? Do I want to give maybe some Toradol also, right? If I want to go narcotic, I can go narcotic and I can give fentanyl 1 to 3 mics per kilo. I can give ketamine 0.1 to 0.3 mics per kilo. I'm sorry, milligrams per kilo. And I'm going to document that RAS, that Richmond Agitation Sedation Score scale, okay? But when I do this, I'm going to make sure I have things ready, right? If I'm redosing pain meds, I better have airway stuff ready. I should have end-tidal. I should be monitoring these patients, and I'm going to pre-medicate them with ondansetron, and I'm just going to do what's best for the patient. So I know we went over by a half hour, and I'm sorry about that, but I thought this was good stuff, and you know, I'll put these up for you guys to actually look at. But you know, I do appreciate your time and sticking with us, and I think some of this stuff was good, and you know, I think we do better as a job, but I do also think that we need to hold ourselves to a higher level than we do already. And you saw everything was in green on that protocol page. That's because that's all done at the AEMT level, because that's what in Ohio says that we can do. All right. So I know it's late, and I doubt anybody's going to have any questions or want to stick over, but do you have any questions or anything before Matt wraps things up? All right, well, we lost about 9 people, but that's okay. All right, I'll pitch it over to Matt.
All right, not too much to say. I am sorry we went over a little bit, but again, I think it's good information. Be sure to, in the next couple of days, to get on and take your quiz and do your evaluation and whatnot. And we'll see you here on Tuesday if nobody has any questions. Thanks for sticking around, guys. Appreciate it.
Hey, Matt, do you need us to raise our hands so you know we're still here?